what's next. I just want to note some apologies. Joe Gibson and Carmen drink water as well, so it's on the record today. So as always, we either start our meetings in public, with either a story from our patients or population or our colleagues. And today we've got colleague stories. So I think we have got a couple of colleagues joining us, Gareth Price and Luke Thompson. Are they with us? Or just while we're waiting for Gareth and Luke, are there any declarations of interest that any colleagues need to note? No? If there are any that arise, then share it up. Hi, welcome. So good to see you there for you. Hi, welcome. Thanks for joining us. So it's Gareth and Luke sharing with us our colleagues story today. I just did a bit of an introduction before you arrived that we always start our meetings with a story either from a member of the public or from our colleagues, and today we're delighted to have you with us. So obviously we've had a chance to look at the report in advance, but hopefully you're going to share a few words with us and bring some of this to life.
Absolutely. Thank you, and good morning everybody. Thanks for the invite, much appreciated. So I'll introduce myself. I'm Gareth Price, Assistant Director of Healthcare Behaviour Management. In essence, I'm the Violence Prevention Lead for the Trust. This is Luke Thompson. I'll let Luke introduce himself.
I'm Luke Thompson, Lead Nurse for Surgical Neurosciences, and I oversee major trauma.
How this work came about, so Luke, obviously, as he's just explained, looks after major trauma. And when Luke's department opened, it's quite evident that the levels of violence and aggression against staff was quite high. Luke reached out to myself and we decided to have a little meeting, nothing more special, just to see the intricacies and what we can do about that. We then decided that the best route, what I've seen through working in the NHS for quite a few years now, is the MDT approach. It sounds very basic, but obviously that brings different specialities, different trains of thought, how we can deal with patients. January of last year, Luke and I had a meeting here, but we invited pretty much everybody who attended Luke's areas of work. So we had domestics, we had HCAs, nursing staff, everybody we needed. And then basically we had, do you want
to say?
Yeah.
So we started it in November 2024 in response to an increase in staff assaults, including 4 RIDO reportable assaults and a case of litigation against us with our previous staff member. So in January 2025, we held an open forum, invited the whole team to come and just, in a safe space, feedback what wasn't working. And then based on that, we built our action log with the MDT and then met every month. And the simplest measures we introduced was the MDT for every violent patient. So that was Gareth came, Rebecca came, therapy came, not so much medics, but you often got an ACP. And it improved the communication about behavioural management strategies, how we're going to manage it on a day-to-day basis on the ground. We implemented some basic escalation processes around security bed watches, where I got involved earlier to manage that behaviour, and Gareth got involved earlier. And another really basic thing we did was we bought a activity trolley. So we literally went to B&M and bought some colouring books, some stickers, some games. Because major trauma T4, T5 doesn't have a day room, and that trolley was something you could take to the bed space and engage the patient, do activities with the patient to stop that escalate behaviour. And over a 12-month period, because I added it up every week, we reduced staff assaults by 49%, and we had 0 RIDO reportable instances and 0 cases of litigation. And the staff have fed back that they feel more confident in managing the behaviour.
Yeah, absolutely, and there's a financial impact as well. We call it bed watch, so our patient watch with security. We tend to jump to that a lot rather than looking at, the trauma-informed approach of advising this patient. And it's these simple things that we're giving the medication at night, but we should be giving it in the morning. Have we sort of done activities, some basic things like colouring? Have we involved the family? Is this is me? And when we find that when we put all them things into place, we don't need to jump to security. who wants security guards looking after a patient? The lens of that is not great either, is it, for the family? So we found that putting that in place has also reduced our bed watch, because how many bed watches we have in Luke?
So just to jump back on that, to give a simple example for those in the room. So the last case we had was a patient that was assaulting the staff overnight, and they actually put a bed watch in place overnight. I came on in the morning, this was a fresh major trauma gentleman with a nasty facial dorsal fracture, and we just said give him some painkillers. Got rid of the bed watch, treated his pain, the violence stopped, and the bed watch costs us £2,000 a day. And through the initiative, we actually went from using the bed watch every week to going 10 months without one. It was about that holistic assessment of the patient and using the different MDT around you to manage the behaviour.
I think the challenge now is to keep that going, but also roll that out across the trust, which is it's not easy, but that's what we're aiming to do.
Brilliant. Thank you for that. It's really helpful. Any questions or comments, colleagues? Okay, I've got a number of colleagues. So I've got the FEEC first.
Thank you. It's one of my voice for some. A massive thank you. Obviously, an area of significant concern for us in terms of impact on staff, and looking at the staff survey, it's one of those areas that has remained an issue for us organisationally. So, just really appreciate the fact that we have an approach to it that is both holistic, supportive of staff, but also humanises the problems that and the experiences of our patients. So, just want to say thank you. Appreciate it. Thank you.
Thanks, Ricky. Chris?
Thanks. Really interesting. Thank you. One of the things that really brought home for me was it sort of punctures what might be a sort of idealistic picture of what major trauma patients are like. And so I think it's really interesting because it sort of brings out the reality of those, of what you deal with on a day-by-day basis. And I just wonder if you could say a little bit more about that sort of, because these are people who are injured and their behaviour is as a result of their injury. They're not bad people necessarily, but
No, so the opening of major, I've worked in neurosurgery for 5 years. We opened major trauma fully 2 years ago, and I would say I've had my eyes opened quite a lot, because we went from having cranial head injuries to having a lot of vulnerable 16-year-olds that are involved in gangs, but forced to work in gangs, a lot of safeguarding. The clientele for major trauma is, I can't think of the right word to describe it, but it's very different. And a lot of the patients don't intend to be violent, so a lot of them don't have the mental capacity, they've got a nasty brain injury. But then alongside that, you've got the people that do intend to be violent, and it's about how you manage that behaviour.
Yeah.
It's been completely different for the past 2 years than anything I've experienced in 15 years.
but major trauma patients are not what we all necessarily think
No.
is it is.
Thank you for that, Chris.
Yeah, thanks. I'm really interested. I was kind of interested, this wider deployment. I mean, are there other conditions that kind of follows from Chris's question? Things like dementia or just patients in acute pain that are then where these approaches can be deployed?
Yeah, absolutely. And like you've said, it ranges from, like Luke said, someone could be in pain in A&E and we're not managing the pain properly, or somebody suffering dementia. So we can look again. So when we initially did the MDT, we had Rebecca Williamson, who was like a falls nurse specialist, dementia specialist, just to look at what we need to do or what are we missing. As I said, it can be as simple as not give someone pain relief.
Yeah, it's about being, every patient's different and every patient's, so I learned all this from Gareth and Becky. So every patient's different, every patient's got different triggers. And the one that always stands out to me, and I know you've heard this hundreds of times, was a young 16-year-old, and I remember his name because it's the same as a footballer. And I literally watched him drop kick a security guard across the room. And it was all because he wanted a cigarette, but no one would take him out for a cigarette. So we took him for a cigarette and he behaved and started to calm down. So it's about understanding what matters to that patient and what those, and then you understand what the triggers are, and then you negotiate around those triggers.
I got called to about 2 years ago now, just not been here long, to a patient having dialysis 3 times a week here at Salford site. In the month of April alone, I think there was 38 day ticks of assault on staff. When I sat down with the young man and I said, has anybody ever spoken to you? And the This Is Me document, we know it's dementia focused, but that is gold dust in my eyes. So I went through the This Is Me document with him, and I can sit here now and tell you he had a teddy in his bag called Lucky that was named after his pet dog. But he's on dialysis, he likes a glass of milk and a cheese and onion sandwich. For his sins, he was a Liverpool fan. You know, that information I gleaned out of him literally 30 minutes. And then arming the staff with that. We didn't hear of him afterwards because we could manage and understand his behaviours. So it does really does work.
Thanks, Tim. Julia?
Yeah, I was just going to point out the great work that Gareth does and the fact that we've got someone with Gareth's expertise. And I think that, you know, when Gareth gets involved in teams, that there's a lot more that we've got to do in this area, a huge amount. And I think some of the things you're talking about, we've got a lot of people with mental health diagnoses in our, you know, not waiting for mental health service, but within our services, we've got a lot of people who suffer from drug and alcohol use, which can sometimes affect their behaviours. And then I think, as Gareth said, it's really important that we look at people as individuals, but also there is a significant impact on staff, because you can't always get ahead of this, can you? Sometimes you are, you know, reacting to situations, and that's when staff do find themselves in quite difficult situations. And I think we used to see the usual things out with like with head injuries, you expect some sort of change in behaviour, but you don't always anticipate where some of this might come from. So I think Gareth has helped us learn a lot, but there's a huge amount more to do, particularly some of our patient population. Thank you.
Liam?
Thank you. So similar to what Juliette was saying, was the importance of this work, and it's inspiring actually, because you may think that we don't tolerate poor behaviours, but we can just read any of our security reports and we do tolerate poor behaviours, because we kind of lump them all together if people are sick or there's nothing we can do, and that has a huge detrimental impact on our staff. And I think seeing something like this about how you can do something to support, because there's organic conditions that mean we have to do something to support our patients and support our staff. And then there are some behavioural incidents as well, which we need to absolutely tackle and not tolerate. And I think giving staff the opportunity to hear something like this really allows us to show that there is a different way to manage it, and you don't have to tolerate. We can do something about it. Thank you.
Thanks, Liam. Suzanne?
Thank you. Thank you, Gareth and Luke. It's a really great presentation. I just wanted to start by commending that person-centred approach, because that taking the time to get to know somebody can be just a little thing, can't it? That can make a difference to an individual. So that's really great to hear that that's been so impactful in the work that you've done. So there's just a couple of points. Is 77% reduction, I think it was, which is tremendous. There'll be other benefits, I imagine, as well. Is a sense of the impact on the team in terms of more sickness rates, lower turnover, more positive environment within the team itself. And then the second point was, Gareth, I know you've done a huge amount of work in terms of that supporting our staff. If there is an incident, that post-incident support, has that been a feature of this work too? Because unfortunately, even though it's reduced to our occasions, and making sure that loop is closed is also really critical. I know you've done quite a lot of work in that space.
Yeah.
So in terms of staff turnover, major trauma has always had a high turnover of staff. I would say the average on the old TAU before GMMTH, the average shelf life of a trauma nurse was probably about 12 months. I think that's just due to the nature of major trauma. It's fast paced, it's hard work, it's high acuity. I think our retention has got better, but we have gone through a turnover within the past 2 years. Sickness rates have always been a problem, but I think that's a wider initiative of the organisation. I don't think we've seen a reduction in sickness rates, but we have seen an improvement in the team and the well-being of the team. We've gone from a culture of being scared of patients, to them actually engaging with the patients and saying, let's get a pack of cards out and play solitaire. sort of thing. What was your question? Sorry.
Yeah, so we were saying about supporting staff, so.
Yeah. So the debrief work was something we started and is ongoing. There's a structured debrief that they use in neurology that's really good that I want to benchmark and move to make trauma, because that involves neuropsychology, the whole NDT, and everyone gets in a room, just not implemented it yet.
Okay, thank you. Thanks, Suzanne. Owen?
Yeah, first of all, I just want to say that this is really exceptional work. It's real top draw work, and you know, that moment, you know, if I go back to you 2 years ago and how you were and what you thought, and then what you've experienced and how that's changed you, and what that got me to just reflect on, because, you know, being in and around some of the safe haven work as well that's connected with this. There still probably is a challenge that we need to think through, because some of the people serving from our communities come from what you might call the darker side of some of our communities, but also some of the people who will feature as a part of that NDT, for example, our people will live in the local communities, and I know of the challenges that that can then mean. Even, for example, if there has been unfortunate violent aggression, which might lead to criminality and other proceedings, it can then be quite a challenge. For example, maybe some of our colleagues feeling comfortable giving witness statements and so on and so on that. So I think a little bit into your point, Suzanne, is work that we need to continue to work with around how do we support colleagues in those circumstances. They might be small in number to get to that extreme, but nonetheless they are impactful. And I think that you're nodding your head, you know what I'm talking about here. It's very, very challenging for particularly our colleagues who live within communities, and what might be out of sight impacts that we need to work through. So I just want to as well just thank you for this really significant work. But I don't think any of us should leave the room not understanding that there's more work for us to do to help support this to be effective, for colleagues to feel confident that they can be a part of the work. So thank you.
Just to add to that, I mean, I completely agree with what you said. If we think that in the past 12 months we've had, I'm sure I can say it in this room, but we've had a hitman in major trauma, and we actually became, I think the proper word, a marked hospital to make sure we were safe and how the staff felt in that situation. So we have gone into a very different, as I said before, clientele of patients. And I do agree with everything that was said.
Thanks for that, Owen. Gertie?
Yeah, thank you. I think I want to bring to life a little bit of the work. I mean, you know, we talk a lot, whether here or in a lot of other forums, about managers and leaders, and actually seeing Luke here today as a manager who's thinking about personalised care for our patients, but how that then looks after our colleagues and how you wrap around that. And you know, you could quite easily 2 years ago gone, this is really, really difficult, and I don't have the headspace. There's too much else to do. Major trauma, as you say, is really busy, it's fast paced. But that moment of pulling back and starting a conversation and seeing such a significant shift, I mean, this is, you know, I want to commend Luke in terms of his management and his leadership, because this is what I talk about in terms of, you know, you are a role model to others, and you won't see yourself in that way, but lots of other people will go, wow, we can do what Luke has done. And it's lovely to hear you saying, I've seen what urology do and I want to bring value, just still striving on. And you know, Gareth and I talk a lot, usually on email. It's a treat to have all of Gareth in person, really. That relentless focus on improving and reducing violence and aggression that our colleagues, you know, families, patients experience when they're in the hospital or in our community settings, really, really key in terms of improving our colleague experience. And we've talked about this before in terms of other incidents, or when we've reflected on the staff survey, and this year's staff survey is still under embargo, but no doubt we will have that conversation in May when it's been released. But it is still a key feature of what we continue to do. And as Owen says, there's always more to do to improve that. But that personalisation for both patients and colleagues is a really positive step forward and lives our values.
So I can say in the past 5 years from my own experience that the way we manage these patients has changed trust-wise. So 5 years ago, I would quite literally, and I have done it a few times, put a patient in a wheelchair, pushed them out the building, put them in a taxi, said goodbye and closed the bed. Whereas we can't do that practice anymore. Things have changed. It's actually harder now to evict a patient because it's moved to an MDT approach, and through all good intentions, and I apologise for someone in the room, a doctor won't let you evict their patient because through their intentions, they're thinking about a different set of priorities. So it's hard to adapt, to learn how to manage behaviour and work through it, if that makes sense, rather than just taking the easy option of a red card and pushing them out the door.
Yeah, just to cross in, and Owen alluded to it, that, yeah, we do have some patients, and I've seemed to create a bit of a niche for this, I think. From me ex-life as a police officer, working at Oldham Hospital for 5 years as their police officer, where I get asked to come now, and there is times where that patient is medically fit and we have to leave. And I have evicted them, for want of a better word, because their behaviour is unacceptable. He's reporting to the police. We need to safeguard our staff, and we need to, look at criminal convictions for these patients. As sad as it is, it happens quite regularly. But again, we have to show positive action towards our staff, that when they come up against that we're going to support them with them.
Yeah, thank you. Aziz?
Thank you, Gareth and Luke, for your amazing work. And those figures, I mean, are just absolutely fantastic. From your point of view, you're talking about I think you're talking about much area, and I suppose to me it's what do we need to do to spread this practice across our organisation? Because what you're doing is helping patients and our staff, their well-being and them getting better. And so it feels we should do this across the organisation. So what is it that you want to ask from us to help to do that?
I think for me, it's just from a trust perspective, is if we're going to go down the trauma-informed approach, that we do it as a blanket approach and not in silo. I try and push where I can. There's only me. Luke does on his departments, but I think we need to all buy into that trauma-informed work because it works. I was sceptical before I did my diploma in trauma-informed approaches. You think, oh, well, actually, when you put it into practice, we see the results. I won't mention staff work, but there to me, I'd love to have a few mini-me's running around, but there isn't another minute.
From a divisional perspective, the way we've tried to roll it out is, I did the test of change over a 12-month period, the evidence it works, and then in January this year, I started it as a divisional approach, and I chair the divisional violence and aggression reduction. Aware, without opening another can of worms, that's all going to change in 2 weeks' time, and it will look very different. And I know that ICD will come into me to try and benchmark practices that I've been doing for medicine, and then we filter all our work through Gareth, and we feed back to Gareth what we tried in. So we've been trying the divisional approach, but also have to rethink it in a couple of weeks.
Okay, thank you for that, colleagues. That was a good discussion, and thank you, Gareth and Luke, for coming and sharing it with us. This is really important to us. Looking after our colleagues, protecting them from violence and aggression when they're doing their role every single day is really important. But I think what this really demonstrates is that we're putting all of our people, patients, population and our colleagues at the centre, because we're trying to understand what the root cause is here. And that trauma-informed approach allows us to do that. I always remember somebody saying to me, we should concentrate on what matters to people rather than what's the matter with them, which is an important distinction, isn't it, around actually getting to understand what are the drivers to some of these kinds of behaviours, really. And I've certainly had a personal experience of that in terms of dementia and some of the drives around that, and the difference it makes when you adopt an approach that supports that person rather than tries to stop them from doing what they're trying to do, really. So I think you really evidence that, and obviously the test of change, you've been able to demonstrate that and be able to suggest to us as a board, which I think from the conversation I'm concluding that we're all in agreement that this is something that we want to continue to do, really. So thank you for coming and sharing that with us, really important stuff. And we've got 2 recommendations in front of us. One is obviously to know the story, which I'm sure we're happy to receive, but also to continue supporting the trauma-informed approach for the range of reasons that we've heard today. So thank you for that. Thanks for joining us.
Thank you.
Thank you. Hey colleagues, it's really helpful kind of reminder again around how important this is to the work that we do as we make in the budget. So I am going to suggest that we move on. We've done the orders for absence declarations of interest. We've got the minutes from the previous meeting that were held on the 14th of January. Has anybody got any questions or comments or amendments on the minutes? Suzanne.
So it's just on section 12.2, the second paragraph. It notes here that I reported a 23.5 million deficit at month 8. That should read and a 62.1 million year-to-date deficit, excluding deficit support funding. We weren't forecasting the 62 million deficit.
Thank you for that. We can make that amend. Any other comments or questions? No, we're happy to approve those. Thank you. Okay, so let's move on then to matters arising from the minutes. So we have 2 items that are in progress at the moment in terms of not due until May. Anything to add on those, colleagues? I think mostly with feedback there in relation to you.
Yep, so
Nothing to add.
nothing to add, so we have things there.
Okay, thank you. And then on the action tracker, item 7, we've got again, page. Anything to add on the action tracker? No. So those are for us to note and receive. Thank you, colleagues. Let's move on then to Owen's report, Chief Executive Arising.
Thank you, Chair. Just a few things to do. I think first of all, just to recognise that we are in the period of Ramadan this moment in time, and also just to remind board colleagues, if you haven't maybe received your little invite, there is an iftar dinner on Thursday, the 12th of March, between 5:15 to 7:30. So just to say that there is an invite to colleagues to come on that. Hopefully you've let that communicated by email anyway around that. I did take, I think it was important also just to take stock of world events at this moment in time. It seems an important thing to recognise because so many people have been impacted by what's currently happening at this moment in time. You know, we've got, for example, clinical colleagues who are stuck in different parts of the world, which has actually impacted on the care that we were wanting or planning to give as an example of where we're at this moment in time. So it felt important to just acknowledge that, and again also to make sure that people, particularly anybody who is significantly emotionally impacted by this, that we have got things like the SCARF programme and to encourage people to think about that. Also, this paper kind of outlines also the recent CQC reports that we've had, the Salford Royal Surgical Services. I know we've got further conversations coming on about CQC about the agenda, but also the work around Rochdale Infirmary as well, where there's contrasting sort of feedback and learning from both. But nonetheless, the thing that's common in both of them is the need for us to keep continuously improving and to move forward in that. Other things I think just covered in the report talk about the NCA wide cancer improvement plan. We've made progress in respect of cancer, and then also the new pathology system, and colleagues have kind of made that look very swan-like. But I can't tell you there's been a lot of work done on the kind of, it might not be visible to people, just to make sure that we land that. So I think it's just important that we acknowledge and celebrate that. And then also a few colleagues took the trip down to London to be a part of the national corridor care, which really has a desire to eradicate corridor care. And certainly we'll be looking to make sure that we contribute to that as we move forward. And then I think just as a final set of things, obviously, we want to make sure that we are acknowledging, the challenges that we've got. We still remain, I know it feels a bit more sunny, but we still remain winter-like pressures. Leo was telling me this morning about, a service user that we've got who's kind of with us and has been with us for quite a bit of time. And in some respects, he's not really with us for what I would call maybe recognised medical situations, other factors, but we still remain to be the point of home almost for service users, regardless of their circumstances and regardless of whether it's the care that we actually are best placed to provide. So I think it's just important that we talk and not lose sight of that. And also talk about waiting list performance and also the nursing pay package. Again, we will touch on elements of this throughout the agenda, because what's unclear about some of these things is about where will the resources come to fund what seem very worthwhile initiatives. But at the same time, as a part of our board discussions today, we'll be talking about how do we manage our financial resources at the same time. So that's probably all I want to say, but I'm really happy to take any questions or comments.
Good, thanks, Owen. Any comments or questions? Lorna.
Thank you. So I represent the Borough Locality Board, the Northern Care Alliance. I attended on Monday evening, which is our most recent board meeting, and specifically we were called out on the pathology programme by our GP community across Bury for an absolute smooth rollout, and commended for the engagement of our colleagues across the organisation did as part of that rollout. They commented very specifically about how different it felt and how engaged they felt on what absolutely echoing what that was a very difficult programme. So that I passed that on to the programme team, but I think that's important to call out that we are, that is not just us recognising that is other parties and service partners that actually have had a good experience of that rollout.
Thank you for that, Lorna. That's helpful to hear. Any other comments, colleagues? Juliet, is there anything you wanted to add on Leo and the corridor care summit?
Okay.
We've got a paper under any other business today. We are, it was inspiring, actually. I think we all came away from that session on, twice I've used this word already today. We all came away from that feeling positive, and that there's opportunity for us to eradicate corridor care, which we know is not something that we want to provide for our patients or for our families and users of the services. We're in the middle of a March sprint, and so we are meeting 4 times a day with our colleagues from across the sites, and really challenging decisions for patients to be on corridors, and pushing patients who don't need to be in our care, who can be better served at home, and really see that. I think we started, it's very early days, we're only the 4th of March, but I think we're really starting to see some positive buy-in from our colleagues.
Yeah, thank you for that. Anything else to add, Julia?
I think one of the things that was really important for us to hear was from the Corridor Coalition, which is a group that have been supported in the development by the Royal College of Nursing, but which include representatives of carers groups and people who use services, and did really talk about the significant impact that being in a non-proper bed, whether that's in a corridor or whether that's in a temporary escalation space on a ward, has on them and their outcomes, but their experience as well. So whilst we do see this coming through in data around performance, but actually behind every single one of those people they're in a place where they are not getting their best care. So I think that was very important to hear, wasn't it?
Yeah, absolutely. And also the impact that has on colleagues as well, in that way. So I think, I think Lee used the word inspirational, it definitely was, and we'll touch on it later on the agenda as well. Any other comments or questions on the Orange report? There's lots in there, lots going on. Thank you for calling out some of those things, particularly around some of the improvements that we've made around some of our anticipated. Yes. Okay, nice. Okay. So yeah, particularly around some of our IT change around the pathology system. I was certainly impressed with the updates I was receiving around smooth transition. We know these things are never straightforward, and it's a lot of involved. So it's great to ensure the team get that recognition for the work that they did around that. So I think it's exceptional. Colleagues, I'm going to move on if that's okay. Thanks, Owen, for that report. Let's move on to item 9, which is the review of quality governance. Julia.
Chair, there's quite a lot of detail in the report, so I won't go through all of that, but colleagues will recall that we said we would bring an update to this board following the Good Governance Institute review of our quality governance. The workshop that we've had with GGI to share the reports and the paper that came to board in January. So this is an update on that. We said we'd bring an update on some of the actions that we've undertaken. We'll be reminded that GGI identifies some areas for us to improve, some variation and inconsistency in our governance, lack of clarity on roles and responsibilities, some cultural challenges in the level of mixed levels of engagement and communication. The governance capacity wasn't necessarily in the place where it needed to be. It wasn't consistent. We've got some work to do around risk management, and we recognise some digital immaturity. They were kind of the key themes, and we've just pulled some of those key things through. So one I wanted to pull out. We developed the NCA's operating model accountability framework, that will be going to the Risk and Audit Committee for a good look at that in April. And in fact, quite a bit of the work here has either been overseen by Audit and Risk or by the Quality Committee. And we're hoping that'll be really helpful in setting out how the organisation will run. We've just about coming to the end of appointing into our clinical leadership model leaders, and we've interviewed over 300 colleagues. It's been a really good opportunity for us to have conversations with colleagues about their aspirations, about what their development needs are. Chair has been involved in the appointments into the managing director roles, and I think everyone has been involved, particularly Rafiq and I, but other exec colleagues have also been involved. We've been really impressed by people that have come forward, the excitement that people have about what the clinical led model will look like, and their commitment to leading here. So whilst that was in progress before the GGI report, a consistent theme is around our leaders supporting our governance. So that and there's development programme in there which will help. Quite a lot of people when we've been interviewing have really referred to our values, talked about patients, talked about colleagues. So hopefully we'll start to shape the culture in a way that we put in our patients' colleagues at the centre of that. There is a specific, we did get some feedback around medical engagement specifically, and there's a little bit of an update where we are around that, particularly around plans to undertake a baseline medical engagement scale, which we'll report back in future reports around that. In section 6, we'll talk about the work we're progressing around board assurance framework. I think we identified we've got some more work to do there, so the team's leading that, and underpinning that we have set up an operational risk management group and an executive risk oversight committee. One of the things that we've asked MIA to do in their first quarter next year is to, probably second quarter, is to look at how well our operational risk management is within our new clinical groups, so we'll be able to get some assurance on that. We've still got some work to do. We all know that we've commissioned GGI to do some further development work with us, and a number of us have had some interviews around CQC well-led prep, and we did have a good workshop last week. And we've still got some work to do around the quality committee, but we have set up an executive-led quality committee, which will hopefully improve the assurance coming through to the quality committee, the board subcommittee. But we'll see some improvements in that over the coming few months. And I think that was all I was going to pick out on there. There's obviously quite a lot of detail in there. One of the things I was going to ask was, is the board content to receive updates in this way, which is kind of giving the detail through the themes? And we have obviously got quite a way of tracking the actions behind that, but perhaps it's probably more helpful to bring through some of the data in those themes. And I think that each time we bring an update, we'll probably change a little bit of the emphasis in there, depending on the work that's going on. Thank you.
Thanks, Juliet. Any comments or questions? Quite a lot of information there and updates. Jeff.
Thanks, Chair. Yeah, of course. In terms of our governance arrangements in general, I would link that to our movement this year to a more medium-term strategic approach to financial and performance planning. And I suggest that that needs to be fed into these improvements. So, for example, on risk, talk to the audit committee about when we renew our World Shorts framework for next year. We should also have an eye to those risks over the medium term, certainly a 3-year horizon in the context of the 5-year integrated plan. That's good.
Thanks, Jeff. Rafiq.
Thank you, Chair. Just wanted to add just a little bit around the medical engagement, because that was one of the themes that was sort of highlighted in the GGI report. So met with colleagues who have been involved in this, and you read that we will progress with the support of GGI colleagues to articulate the constitution for that, which we'll have a draft of, and then we'll bring that back to the board in terms of how that aligns with connectivity with board. And the medical engagement scale is something that we don't have experience in the organisation, so we're just working through what that would look like. But essentially, we see that as being a cyclical thing that can give us a bit of direction as to where we're going. We have got resident doctors in this as well, who are a little bit more tricky to make sure that they're connected with because of the turnover and the rotational aspect. So the things I just wanted to highlight.
Yeah, thank you for that. That's helpful. Any other comments or questions? Quite a lot in there around the progress that's being made. Chris.
Yeah, and there is also there, isn't there? There's a lot happened. I certainly feel, I think, from a quality committee point of view, the creation of the executive led group that Juliet referred to, I think, is an essential step, and it already feels that the information coming to quality committee is much more appropriate and assurance based. So that just to confirm.
Okay, thank you for that. Okay, if there's no other comments or questions, I think this highlights this is a really important piece of work for us to do, wasn't it? And then a series of recommendations which we discussed in the public board in January. And this is an update in terms of what we've done since then, which is a lot really, isn't it? And certainly as a board, in terms of our focus on this, I think it's been really heightened and helped by the work that GGI have continued to do with us alongside us. So the recommendations are asking, are we assured in terms of progress? Are we assured? Yeah, thank you, colleagues. And then also to advise that audit and risk are continuing to have oversight of this, which we note. And then a question around if we're happy to receive updates in this form in the future. Yeah, happy to do that. Thank you. Thanks, Julia. Okay, I think it's you again on item 10 for the CQC update.
Thank you, Chair. There's quite a lot of detail in the report. Just to remind everyone, Care Quality Commission regulate health and social care activities in England. I am the registered manager for the Northern Care Alliance. We've got a number of locations which are all registered with the CQC, and we're registered to provide a whole range of services. As such, the CQC have got powers to enter and inspect any area that they wish to do on a they don't need to be invited, they can arrive as they like, and we're pointing out that the CQC are starting to increase the numbers of times that they come in and inspect services. And we've got in report the recent inspections that they've done, all of which were unannounced. Just to remind board members, often the inspections are triggered by data which they triangulate the background related to complaints, incidents, changes in circumstances, or indeed some national changes which the CQC have got some responsibility to go and show themselves and show the public that services are safe. You'll see we are obviously you'll look and see that there's been a focus on medical core services. We've had 3 medical core services inspections, 1 urgent and emergency care inspection and 1 inspection of a surgical service. There are key themes that are coming out of all of these inspections, detailed around specifics around, and they have inspected Rochdale, Oldham, Bury and Salford, so they've inspected all of our major hospitals. I've inspected community services recently, and the key things that are coming through will predominantly, I would say, would sit around staffing, particularly nurse staffing, but also including medical staffing and our patient flow. So that kind of refers to some of the issues when we think about the work that we're doing on corridor care. So all of this work that we're going to do around improvements will have an impact on how the CQC their ratings of us when they continue to conduct inspections. The detail of the work in there, a little bit on the section 29A1 in notice which was given following the inspection of the surgical core service at Salford, and this is particularly around staffing levels across the surgical wards and as identifying risk to quality and safety, and some of that was related to patient flow through through those wards. We have we've provided some regular updates. We did have an update at the quality committee, but we have increased staffing numbers in those areas. We continue to have a focus on recruiting a substantive workforce, but we do also, to support safety, have a significant use of temporary workforce as well, as we'll see in other parts of the board reports. And so we'll continue to focus on substantive staffing workforce, and we've got very few vacancies at registered nurse level. We've got more at an unregistered level, but we're doing quite a lot of focused work in those areas. We can see those things come through. We did take a report to the People and Education Committee about where we were with nurse staffing. We are having an engagement meeting with the CQC at the beginning of April, where Owen's Chief Exec and I will be meeting with CQC inspectors, and we'll talk through some of the work that we're doing there. And the CQC do attend the policy improvement region and also the quality, the QSAM meeting, kind of what that stands for, which we have with the ICB as well. So we do have contact there, and we are more or less in daily contact with CQC. We've set up a CQC oversight group, and we've had support of an ex-CTC inspector, Ellen Armistead, who's really helping us there. We are making progress. Progress isn't as fast as I would like it to be, but we do need to take a bit of time to make sure those changes are consistently embedded. And we are really aware of supporting this through the transition to CLM. So we've got a really comprehensive action plan sitting behind all of this, which is drawing in details from all of the previous inspections, plus these ones here, plus intelligence that we're gathering from our conversations and our interactions with the CQC on a more or less daily basis. Obviously, we're feeding in the work from the Good Governance Institute and triangulating against that. And the CQC Oversight Group will report to the Quality Committee, and our Quality Improvement Group will be led by me. And I think we did have conversations, Chair, didn't we, about whether we could get some support from a newly appointed non-exec director into the monthly meeting that we're going to put up to test our assurance. So we'll be able to provide that assurance in a number of ways. So I'm hoping that gives you the update that you need in relation to CQC activities. And I think we did spend a little time, didn't we, at our GGI workshop talking about CQC well-led prep, which we would anticipate coming anytime soon. And perhaps we might even get another further unannounced inspection. But just do with that as we usually do. Thank you.
Okay, Brilliant, thank you for that, Juliet. Aziz?
Thanks, Julia. I mean, there's a lot here. I don't think we should overlook that medical care at Rochdale was deemed good. That is something to be very happy about and really nice to read that. And there's some really difficult stuff in the Salford site, but they also found really areas of practice with high compliance and training, regular appraisals, which I have found out about since I joined this organisation, and adequate medical staffing. I think the thing that sort of stuck out to me was that, two things, which is worrying, which was that they didn't feel that meaningful progress had been made in relation to most regulatory breaches identified in the previous inspection in December 2022, and that's kind of a huge concern. And we tracked as an organisation, there was a plan. It was tracked through quality committee. We were told that each one of those things were done. So something we did didn't work, and I think we need to consider maybe the new governance process will help that. Each aspect of it. People committee got the people bits of the CQC plan, and quality committee got the quality bits. And we ticked them off one by one, and sometimes they went backwards. I remember there were stuff that we thought had been done, but actually it hadn't. So it felt like we had a process that worked, that was addressing this. So when I read this 4 years later, that really concerns me, that a process that we put in place to fix this, they're saying there was no meaningful progress. That's really scary. The other question is, the service has formally, on October the 21st, when the inspection was done, the service was formally required to make significant improvements to the quality of healthcare provision by 31st January 2026. But it's 4th of March, and it doesn't say here whether we've made those, because it also says failure to achieve these improvements within the specified time frame may result in further regulatory action. So we do need an answer today whether we've done what we were told to do by the 31st of January, which is 5 weeks ago. And there's no mention of that. So I just wonder, what were those things they asked us to do, and have we done them?
Okay, do you want to pick that up, or do you want me to take Tim and then respond after that?
Yeah. I'll take the questions and respond afterwards. Yeah.
Tim?
Yeah, I find this a really, really kind of helpful and important report, Julia. So thanks for preparing it, because I think it is difficult. We kind of get updates in sequences inevitably with how the regulation works. So it's really important to kind of be reminded of what we've seen and when, have that in one place. So thank you so much for that. The only kind of question was 6.5, the transfer of the action plan and ownership to the relevant triumvirates. It's kind of how attentive do we need to be? Is that a splitting up of the action plan? Is that something the quality committee needs to kind of be alert to? So it's just a general sense. Is there risk around that process?
Okay, thanks, Tim. And I suppose a question for me, following on from the point that Aziz has made, is one of the things that's new here is the CQC oversight improvement group. So is that where we think that some of those things might actually, have that kind of, governance oversight, or where we perhaps didn't have that before? I suppose it's a question for you.
Okay, so I think when we came to probably, I can't remember what month it was, we came to a board meeting where we gave what we felt would be a self-assessment against where we were with the CQC. It was probably May time, June time.
It was a July development session.
July development session, where I think where we discussed that we would probably still require improvement in organisations. So I understand the point you're making, which is we haven't made the progress. I think we identified ourselves that we haven't made the progress. So in the CQC are reflecting there something that we perhaps did know ourselves. I think we've seen a GTR report which has identified that we needed to make improvements in our quality governance. And I think until we do make those improvements, we won't necessarily see the tracking of the improvements that we should have been making against CQC inspections. I don't think those two are independent of each other. So I think clearly actions were undertaken, whether they were sustained. And if you think about staffing, nurse staffing, for example, improvements would have been made at the time. Unless you keep up to all of those, then you will see deterioration. So I wasn't able to time, but I wouldn't say that it was necessarily false assurance given, but perhaps what was really required was this attention to the detail over time. What in the improvement group that we've set up, what we'll be seeing, we won't sign off any actions has been completed, and we've got evidence of assurance over time, and we'll determine what that time period looks like depending on what that is. So it'll be a criteria where we'll see some sustained change, and that's the sort of way that we're embedding some of the work that we're doing, in fact, through the improvement board and other areas where we're looking for some sustained period of implementation. So that is one of the things that might be different to the way it was before. So that's what that group will do. And obviously for something like, you know, staffing levels, we haven't yet seen that sustained period of improvement. So your request about are we assured that we've got all the actions in place following the regulatory notice around the Salford Surgical Core Service? I don't think we've got sustained evidence that those staffing levels are where we need them to be in the way that we want them to be, but we have made some progress. We're really transparent with the CQC about that, and when we did meet with them, and I think I've reported to this board as well that I think we've still got some more work to do, particularly around nurse staffing in surgical core services. So I think the CQC are expecting to see improvement. They also don't want to see something which doesn't look real. So one of the things we've got to make sure is that we're not moving, kind of not moving staff from one place to make another place look better. So we are talking there, particularly on the staffing levels, the recruitment that we're undertaking, the vacancies that we've got, the work that we've done around over recruitment into some areas, the way that we manage sickness absence, because that's a key driver of staff unavailability. In relation to into the movement into the triumvirates, the helpful thing about this is there are some consistent themes across the plan, which aren't necessarily specialty related. So culture, staffing, medical staffing, and flow, use of temporary escalation spaces, all those things are fairly consistent, and particularly around our inpatient areas. So I think we're just making sure that we move the assurance for the improvement from where we've got them in the care organisations now into the clinical groups and into those services. Obviously, we're going to be a clinical ed model. We're meeting with the triumvirates. Rafeek's meeting with his medical colleagues. I'm meeting with my nursing ones this week. Rafeek's meeting and Liv's meeting with hers. And we're collectively meeting with them all at the end of March, where we're really clear about their leadership on this piece of work. So I think does that answer all of those points?
I think that given we were told we had to do something by the 31st of January, which is 5 weeks today, I'd have expected some narrative. I mean, you've given that narrative actually. I would have expected that narrative to come with it, to be a paper here to say, this is the CQC report. They asked us to do this by the 31st of January. This is what we've done. I think that's how things should be reported. I don't know if I'm only thinking that, but I just think there should have been some narrative on that.
So, you will recall that at the January board meeting, we did bring a paper on a nurse staffing update, where we talked about the changes that we'd made, and we referenced that into the surgical wards that were particularly identified during the inspection. So we did bring an update on where we'd increased the establishment in those areas and made some adjustments. So we did bring some assurance and referred to section 29A at the January board in that paper. If there's anything else that I've missed, but you've got that from the verbal update, that's I can bring anything else, but I do believe that I have provided some evidence where we were around staffing in that paper into the January meeting.
The January board was before the deadline. I just think that if there's a deadline from CQC that asks us to do something we should report after the deadline that we've done it. That's all. It's a small point.
As your microphone's off, if you do listen to the addiction, just pop your microphone on, please. Thank you.
Sure.
Sorry, I just think that the January board was before the CQC deadline of asking us to do something. CQC's asked us to do something by the 31st of January. After that date, at the next board, we should have just a short narrative to say, this is what the CQC asked us to do.
Sure.
We have done it.
Yeah.
But, you know, I accept what Juliet said. We're not making things up to the CQC. We're saying, actually, this is really challenging. We are working really hard to do this, and we have made these changes.
Okay.
That's the point.
I think it's a point well made. I think what I've heard today is some of the things that are taking place. So staffing level changes, we've got ward reconfiguration, but importantly for us, in terms of those assurance mechanisms, we've got a place where there's some clear oversight of all of those actions, which wasn't in place before. I think one of our jobs here is to make sure that we're assured on those mechanisms rather than seeing everything ourselves. And I think that's one of the things that's important that you need to reflect on. But take the point that you want to see that more clearly. I think quality committee is obviously at the place where we'll see that really clearly. And I know you're a member of
I
quality.
am really a quality committee.
I mean, Chris, do you want to add anything in relation to that? Maybe you'd like to.
So I don't know, a couple of observations. So this is really it is really complex, isn't it? CQC timescales are quite difficult to deal with, but I think we've just got to work on making sure that we've all got sight of this stuff, which we have, and this is brought together in one place through quality committee. So I think that's the. Can I make a different point?
Yeah, Rachel, sorry, Rachel, jumped ahead, Chris. Go ahead.
Have I jumped ahead?
No, carry on.
Quite rightly, we spend a lot of focus on when CQC have found adverse findings or they've produced regulatory actions or whatever, these sorts of things. We spend time on that as right, and as he's pointed to us, needing assurance on those things. I just wanted to make the comment that in the quality committee paperwork, it is quite clear that the other things that you do in terms of relationships with the CQC, Juliet, in terms of responding to the many inquiries that there are, and also the sort of things which don't meet the threshold for visits. There's a lot of work that goes on there. And I think for months we'd seen the fact that we were very behind with some of those contacts. And I think yourself and Caroline in particular have worked hard to make sure that relationship is improved. The reason I raise it is I think it is a symbolic thing about relationships with CQC. It's one of the things which they look at, isn't it? So whilst it's right that we focus on the big stuff where adverse findings, I think that context of the work that's been done for the ongoing relationship, accepting what as he said in terms of sort of a bit more clarity and things, maybe, although it's all there, but just how we see it. That other stuff is for me is the assurance that we get on that relationship with CQC.
Okay, thank you for that, Chris. Rachel.
Thank you. It's so complex, so many different pathways, so many areas that CQC are looking at. Obviously, we want them to look at it. We want them to tell us if we're not doing something right. We want to do something about them. And I think I really appreciate the governance structure that you put in place around those layers, the groups that are focusing on it. And I think where I need to do better is, when the paper came in January, I might not have had that CQC lens. I was looking at it at the paper level. So actually that assurance from that group will be very helpful. I do wonder if there's some value in us looking at the assurance approach that we have applied elsewhere in the organisation. Perhaps at some stage when we're happy, Helen Armistead has come in, provided some of that support, actually that we can get somebody internally to then look at that and do a bit of a dashboard review of where we are with things to support some of the ongoing improvements, and how we can then move forward as a board that actually we're comfortable with where we are. But in general, I think we're putting the focus in the areas that are giving me reassurance at the minute. So I'm very grateful for that.
Thanks.
Okay, thank you. Jeff?
Thanks, Chair. Through you, Chair. Julia, my recollection of the update in January is that the groups of staffing at CQC are looking for staffing levels could be accommodated by looking at things like sickness and vacancies and managed financially within the overall envelope of staffing, particularly on nursing. Is that still, was that the case then? Is it still the case now? We can make these changes at the speed necessary within the overall financial envelope of nursing.
Do you want me to answer that?
Yes, sorry.
Yeah. I think we believe that's the case. So we have got a big spend on temporary workforce in nursing. We've got very small number of vacancies in the registered workforce. We've got a large number of vacancies in the unregistered workforce. I believe when I brought the staffing paper in January, I did describe within there improvements that we need to make around establishment setting. So we're reliant upon data sets which tell us whether or not we've got the right amount of staff. And in that paper it tells you there's a science bit of it and there's an art bit of it. We do need to improve the art bit of it because we're trying to understand acuity, which is something which is a professional assessment. We had Luke here earlier who talked about how you might, here's a patient with multiple fractures and minor head injury. How do we deal with them? Actually, we need to sit and spend some time with them in order to kind of de-escalate that. That's a judgment decision. So we do need to improve how we're using the kind of the professional element of understanding what are the requirements of the workforce. And what we're seeing in the temporary workforce spend is a significant amount of that professional judgment being applied to acuity as well as sickness absence. So I still think there's work that we need to do to feel assured that the staffing levels that we have got budgeted for and each ward and department has will meet the needs of all of their patients at any given time. But the spend is so significant that at the moment we're kind of hoping that I'm not at the point where I'm anywhere close to saying to Suzanne, I think we might have an investment conversation here. I don't think that's going to happen this year around those numbers unless we do something, unless we're providing services in a different way. So I think it looks like that now. I was just going to make a point and track into Aziz's point. If there is something missing on the assurance, can it be really clear? Because we do set quite a bit to quality committee, do things to people in education committee, we bring things here. So obviously it's really important that the board is assured on this. So can it be very specific, perhaps coming from Chris, about what is not being received here, as opposed to in anything else that's coming through me. It's very important.
Sure.
From a CQC well led, that if there is anything hanging here, that we've got that answer there. So we really appreciate the specificity on this, because I'm bringing quite a lot, and if it's not quite hitting the mark, it's not that it's not there. I just need to make sure it's been presented and presented like this.
Sure, yeah, and that's one of the recommendations, isn't it? Whether or not we're supporting the approach improvement on the site. So it's our opportunity to say we want something different if we want it. So Chris.
Just one thing, I just echo Rachel's point. I think that I can't speak for non-exec colleagues, but for non-exec colleagues, it's not always obvious that a piece of information translates and triangulates or corresponds to a piece of CQC action. So I think the other message would be trying to make it crystal clear where it does. And that, I mean, I know you do, but sometimes it's not immediately obvious that paper relates to a CQC.
Yeah, that could be me.
Still, because it's all. I think it's all there.
Okay.
Does that make sense?
I guess it's for all of us around the table. It's all of our responsibilities to make sure that we know that, we understand that. And, you know, one of the things that I think would be really helpful for us to hear today is a little bit of that around, and I think you've already done that, Chris, you know, around we discussed this at quality committee. So and you know, fills in the gaps for people, even though there are reports on the paper that in the pack that tell us what was discussed at quality committee or people committee or wherever. I think it's helpful to hear it around, you know, what was the assurance. But I think those should be some of that questions as well, relative. So they're legitimate questions to ask. What did you consider? You know, what assurance did you get? I think they're legitimate questions, but we can't say, you know, don't tell us because you know, we need to be told because we need to ask as well, don't we? So it's a responsibility for us all, really, I guess. And I'm just trying to make that clear. I think it's a helpful report. I mean, I think you said, Juliet, that you'd like it to be more happening and like the pace to be a bit quicker. I think, you know, we're going to map it into the new clinical groups, which I think will be really helpful. And we've heard about, you know, the new leadership that's going to come with some energy and enthusiasm, certainly what I've seen already. So we're hopeful that this will be really grasped and taken forward because this is really important. This is important to our colleagues. It's important to the people that we serve that we get this absolutely right. And understanding what the CQC are looking for is an important lens, but it's not the only lens that we should be looking at this from. This is about, you know, improving services for our population and our colleagues. So that's, I guess, what I want to say. Just one issue for me, or question, I guess, really around how we're keeping people engaged and communicating around the changes that we're making. So obviously we've heard today, and I'm sure people watch back our boards to follow some of that. But if they don't, how do we let them know about the sort of wider improvements? Because it will be a concern for colleagues, even colleagues that are not involved in these service areas, that see reports that are coming in from the CQC. So how do we keep them engaged? And maybe it's a question for Julie. I don't know. Is that something we're able to do to sort of keep our wider colleagues involved?
Yeah, I think there is in the paper, there's a section on communications as well. I think some of that is around what we do at the time of an inspection. I'm sure people get information at the time when it's actually done. But yes, we, as part of that, we'll need to we'll create a communications plan, I guess, as we step through it. But quite a lot of the work we've done has been around individual places and services, to be honest, at the moment. But I agree that it's more of a collective, how we're doing with CQC.
Yeah, I mean, I think it's just that ongoing kind of checking in where we're up to, because I think, you know, obviously update colleagues at the time, and particularly those that have been involved in the inspection, but I think it's just that wider reputational response. These are things that be really helpful. So that'd be great. Thanks, Julie. Juliet.
On that, an example, speaking to Tracy Walsh, who will be an incoming director of nursing for families, anaesthetics, critical care and theatres, and she you know, she was talking about how she's encouraging her staff, and she's doing it to encouraging people to be to say we are recruiting, you know, we are bringing more staff in, we are training more staff, we're going to do some bed reconfiguration, we are focusing on flow. So you know, so we have got our leaders out there on their day-to-day meetings with part of it's, you know, some of the concerns that, you know, staff have got about staffing levels and pay, is to try and reinforce the work that we're doing. So I'm not going to say it's everywhere all the time, but we're definitely hearing of our leaders talking to their teams about what it is that we're focusing on, what's important to us, and obviously having those conversations with our, you know, nursing, AHP, midwifery, AHP leaders about the investment we see on the face paper here, won't we? Where, you know, with the staffing levels in maternity, you know, where we need them to be. So you know, we are talking to staff about the things that CQC have pointed out to us. So we'll always be able to do more on that level, but I think it is becoming more part of our everyday language about the changes that we're making and why we're making them.
Thank you. Chris, you still got your light on.
Sorry.
Okay, colleagues. So there's two things for us. One, to know the report, which I think we can do that, and also to support the approach to improvement and oversight. And I think there was a specific ask there around if there is anything that we think is specifically missing and that we need assurance from them, if we to pick that up. So keep that up outside the room if there is anything. Don't be okay with that. Okay, thanks, colleagues. So let's move on then to the integrated performance report. Leah, can you take us through this? Or yeah, thank you.
Thank you, Chair. So I'll take the report as read in terms of the special reports concerning the stillbirths per thousand and the postpartum hemorrhages will be picked up later in papers in maternity services. Colleagues are here, and other exec colleagues may wish to add to any narrative as we go through the report. So in particular, our sickness absence continues to be above target, and Gertie may want to comment on that later, but obviously that notwithstanding that it is important for all of us to play our part in ensuring that our colleagues are back into work to allow us to deliver the quality that we had talked about in the earlier points in this meeting. In terms of moving into performance, we have our lowest waiting list, total waiting list in 4 years, and that continues week on week to reduce, which I'm really pleased to report. And a significant chunk of that is through our validation of our waiting list, making sure that it is clean and that we are focusing on those patients who are waiting for treatment, particularly some of our longest waiters, although 52 weeks and 65 weeks do continue to present challenges for our longest waiting patients. Some of that is relating to our theatre productivity for some of our very longest waits, and we've had delays in our rollout of our IT system, which was supporting enabler in theatre productivity, and also we had a heavy reliance, and we have a heavy reliance on staff picking up additional activity, some of which has not been picked up recently due to which has been the last trust in Greater Manchester implementing standardised rates for colleagues. Juliet and I are working closely on that to support and put in interim and more long-term measures. And I am leading on a piece of quality 3 hours processes, reality, response and results for our theatre colleagues, particularly at Salford. And the first session of that, over 40 colleagues joined us, and we can see thank people for their candour in some of the actions that we've got to deliver going forward collectively. Moving on to our type 1 performance, it is better than the national average, but still not where we would like it to be. And we are focusing, you will see a paper on any other business, on particularly on care in the right place to ensure that we eradicate corridor care. The chair has joined us on our interviews, Rafik, Juliet and I, for the managing directors of each of the clinical groups. And we have asked the question around their ownership, their clinical group's ownership towards improving flow across the organisation, because this isn't an emergency care alone issue. This is a problem for all of us, and how do we contribute to that? So we are asking colleagues, and we are inspired by some of the responses and the collective ownership that we will see going forward in that. In terms of cancer, as Owen described, we are continuing to see an improvement in our overall cancer performance, again not without its challenges, and particularly the demand that we see from dermatology. And as the sun is starting to shine in the last couple of days, so will our demand on our dermatology services, and therefore we are looking at alternative steps in terms of how we manage demand and what alternative models we can continue to use, explore and develop in dermatology. That was all I wanted to say. If colleagues wanted to add anything in particular areas.
Okay, any colleagues want to add anything before we invite any questions or comments? Rachel.
Thank you. I wanted to ask you about overpayments and staff turnover, please. So overpayments, it's been reducing for 6 months. I just wanted to know, is this been a conscious outcome of work, or is this a coincidence? You know, have we been putting something in place? Because obviously it's a very positive continuing reduction. I just wanted to know if we've learned something from it, if it has been conscious.
Yes, it has. If you'll recall, I think we had a very detailed conversation a number of months ago about overpayments. We do routinely review it here at board. We've done a very collaborative piece of work, particularly with finance colleagues, around improving the oversight, the rigour, how we approach the clawback of overpayments. So it is something that we continue to work on. That's alongside a piece of work with the people colleagues and the rostering colleagues to try and remind managers and leaders around the importance of the timeliness of putting in relevant paperwork for ESR. One of the things we know that drives the majority of our overpayments is late changes, and one can understand if you're a ward manager or a team leader running a busy area, it'll be once in a blue moon you'll probably fill in an individual change form, and they do get missed, so we send monthly reminders out. Suzanne might want to add into that as well, Rachel, around the work finance have been doing. We are picking this up and tracking it through the performance oversight meetings as well, and really helping areas to understand the impact of those overpayments. So it is absolutely something we've focused on here.
I just think it's a really positive sign of where, you know, where we've got that conscious investment and we're seeing that continued improvement. And obviously it's avoiding a very stressful time for staff and colleagues if they are overpaid. So, you know, this was really positive to see. Next one is about staff turnover. It's looking at the minute like the lowest in 2 years. And I wanted to know, please, if this is a sort of NHS average. Is this what we're seeing across the NHS at the moment? And how do we feel about where we currently are landing around staff turnover? Because obviously there's a positive and a negative staff turnover. And I just wondered where you felt we were at the moment. Thank you.
Yeah, I mean, it's tricky to benchmark ourselves because how an organisation views its turnover differs by each organisation. Some will include internal moves, some won't. We are performing reasonably well, but on par with other colleagues across Greater Manchester. There is a degree of slowing down of movement, which is a reflection of the financial climate. We know we've talked routinely through here about our vacancy review process and the need for us to, we have said, the most sensible way for us to achieve our headcount reduction is to review every vacancy to ensure, through a 3 hours process, that we are doing the most effective way of working. So we are seeing less opportunities in some areas than others, so that is seeing some slowdown. But to give you a really clear answer on a benchmark, I mean, we perform well across Greater Manchester, but I'm equally conscious we don't necessarily measure the same things that other organisations would include.
And is there anything sort of worrying about our current position? Anything you're concerned about?
I wouldn't say I was concerned about it, Rachel. A degree of turnover is always healthy for an organisation, and one would expect to see that. We know we will probably see an increasing position. We did an awful lot of work, probably, I mean, before my time, but Aziz will know, 3 years or so ago, around really trying to focus on retention, particularly for newly qualified nurses and our healthcare support workers. We do see high turnover in our healthcare support workers. It is a very difficult, challenging job, but equally, a lot of those colleagues who join us as a healthcare support worker then move forward into nurse training or AHP training, or it gives them the ability to move into other roles. So it's not that we're necessarily losing them, they are moving ahead in their career. We will expect to see an increase in this as we go through the financial year ahead of us, because we know we have a challenging CIP target, and we have, Suzanne and I have talked quite a lot around, and Suzanne will cover it, I'm sure, in the finance look ahead, around how we work with our clinical groups moving forward, to be really clear about not just a control total, but a staffing total and how they work around that.
Good, thank you.
Great, thanks, Rachel. Rafiq.
Thank you, Chair. So just wanted to add in the quality and safety section, there's a reference to the piece of priorities being developed. I just want to add those have been agreed, and they were around waiting safety, teaching diagnostics, and some growth of reliability and safety there, and discharge communication. and colleagues will also see that never events continue to be an area of concern for us, and it's a topic both of focus internally and some of our discussions with ICB colleagues, and an external review has been commissioned, should give us some external insight as well. That'll take, we think, about 8 weeks to and also capture some of the locked issues that we've discussed at the board before.
Okay, thank you for that. That's helpful. Aziz?
Hi, yeah, I'm a bit confused about something. I'm misremembering something, but there was something that we were doing in terms of dermatology that we were not going to do anymore, and that the services were going to be provided by someone else, and about the impact that would make on our dermatology waiting list. And I just wondered where we got with that process.
So that it was community dermatology service that we were providing and continue to provide. We have served notice to say that we will no longer be able to provide that from the 1st of April. However, Owen and myself are in conversations with the ICB because at this moment in time there is no alternative provider. We will have ongoing conversations with that to manage that risk.
And Tameside and Blossom, what did they resume some work? I mean, what's the impact of that? And are we getting money from the ICB or support to bolster the extra work that we're having to do because of that?
Yes, so the Tameside and Blossom, we've seen no changes in recent months. We're anticipating that there's still sustainability issues, and therefore we could see further withdrawing of services. Tameside is particularly critical risk for us in dermatology, but at this moment in time that hasn't transpired, and we have progressed with funding.
Okay, thanks, Aziz. Suzanne, do you want to respond?
Yeah, it's just on that. Yes, so we try to make sure that there's a really clear joint understanding between the Tameside, the ICB, and ourselves. So we have got confirmation of the funding for the element that's moved, which has been an ongoing debate discussion. And any changes to that, we need to make sure all three parties are clear about any changes on that. So that's known, isn't it? It's a known thing. So we cannot absorb any more into our organisation unless it's in that way.
Okay, thank you for that. Jeff?
Thanks, Stuart. We spoke earlier in the meeting about our contribution to the national determination to eradicate corridor care. Much welcome ambition from my point of view. Are we intending to incorporate into this report a way of measuring corridor care in our hospitals and focus on eradicating it?
Lee, did you want to get that?
Yes, so we can incorporate that. There is one of the elements that we looked at in the session last week nationally, that there is no real recognised definition of corridor care, and therefore we're expecting national guidance very soon on what that definition is. And then there is our ability to count it and work it through. Certainly it will be a feature of our work that will go to our improvement board. Once we've got the definition, then we will be able to capture it and report it.
I think perhaps we can touch on that when we get to the paper as well, because I think there's a series of recommendations in there that kind of allow you to define in some way what you're going to be measuring really. And certainly when we talked about corridor care, we were thinking flow in general, and actually being the whole responsibility of the trust, not just individual entry and exit points, for example. And so I think it'd be good for us to sort of say what would that look like in terms of dose success measures. So Juliet mentions about temporary escalation spaces, for example, and the usage of that, and so on. And we're certainly doing things to tackle that right now, aren't we? To so I think being able to sort of have a suite of things that we're going to look at around that would be helpful. It's good, great. So yeah, thank you for that, yeah. Tim?
Yeah, I mean, it's kind of in the same area, really. It's around percentage of patients waiting over 12 hours. kind of, I mean, we're at our worst position, it looks like, for 2 years, doesn't it? In terms of, I'm kind of wondering, just in one way, should we kind of humanise this a bit more in our IPR? We talk about percentage, should we just put the number in as well? And maybe kind of do a spotlight on, you know, potential harm or just an individual case, because I kind of think I feel a bit immune to that. And it's picking up the chair's point, I suppose. Last month, we were talking about improved escalation, discharge pathways, learning from Berry, and stay collaborative. It's kind of, that sits in last month's minutes. This sits here. The two are detached. It's kind of understanding that range of work and the ambition of improvement that will make. So I guess I hope from what you've kind of trailed for the paper and what you've looked at last week, that I'm sure you'll cover that, but that's kind of, I just feel we need to be seeing a bit more, either temporarily on this in terms of what it means for the patient.
I think you're absolutely right, Tim, and I think that was what probably hit all of us that were present at the session last week. Around, we heard the stories from the different partners and stakeholders in this, including colleagues, including people that were impacted in terms of their dignity, who were being treated on corridors. And I think it was an opportunity to reset, I think, in everyone's mind that this is something that we need to be dealing with day in, day out. It's not something that you just read a number in a report and say, oh, okay, what we're doing about that. So I think your point about bringing it to life in a human way is a really relevant one in terms of the conversations that we had. And you couldn't fail to be, I think, inspired by the opportunity to say, this is not happening. We're not going to continue. It was a real call to action of, we cannot let this continue. And if we walk past it, or if we accept it, we're normalising it, and that's. So I think that was the purpose, and I think that that's why it's sort of featured in those managing director conversations about this is everyone's responsibility. What's your role going to be in that? So yeah, I think you're right. I don't know if you wanted to add it from Ollie or Julia.
So you covered it really, in terms of how inspiring it is, and this is the percentages don't do justice. The 12 hours is also not just patients waiting for beds, but patients who are not admitted. So therefore, what can we do differently for those patients? Because this isn't just about beds, and I think we don't see that there are other things that we can do. And there is a new drive in March around zero tolerance of patients waiting over 24 hours in an ED department when occupancy is below 92%. So still an acceptance, but there will be some patients waiting above 24 hours when bed occupancy is so high. I was having discussions with Owen this morning about how we make sure that he is personally cited on any of those individuals who wait that long. So it really is setting the message to the organisation that this is something we intend to eradicate.
Thank you, Juliet. Did you want to add to that?
Yeah, I mean, I think we'll pick it up under the agenda item. I mean, Julie did do a really, it's a late addition in, and there's a lot of information in that paper, but it's helpful to understand what exactly we're going to focus on here, as opposed to what we're going to focus on in the background.
Thank you. Okay, Suzanne.
Thank you, Chair. I just wanted to respond to Rachel's point. I could get to at the time. You were asking about what is the risk of turnover, and do we see any? It's just some insight, real insight. Because I think we've probably seen that in corporate services because of some of the reasons that Liz outlined. But I think it's given us opportunity, particularly in my portfolio, because as part of the clinically led model, we're centralising the finance function across the organisation. So if there is a slowing down of turnover, it gives us opportunity to really, really focus on staff development, talent management, succession planning, because we've got, a decent sized department and we can offer opportunities within, even though we're not seeing some of the movement that perhaps we would have done before. So just a bit of insight.
Thank you. Gertie?
Thank you. Yeah, I just wanted to come back in on the sickness. I said I would provide some more context around sickness absence. And I think, we've talked a lot in terms of the impact in terms of our colleagues and our patients and our finances of sickness. And it is clearly an area that we have a continued significant focus on. It is higher than it should be. And I thought it would help to give assurance to the wider board of some of the work that we see, both through the People and Education Committee and the challenge and the review we have at the performance committees and at things like the Improvement Board. We had a really interesting deep dive session at the February PEC, where we had a number of colleagues from across the organisation, particularly Rochdale Theatres and Sterile Services and Estates and Facilities, come and talk to us and really talk about the impact of that shift in personalising how we look after our colleagues, the timeliness and the impact of the timeliness of welcome back, return to work. We heard about 34 colleagues being absent in October in Rochdale Theatres and the impact that has on a team of around about 100 colleagues, and how the theatres lead had really taken it himself and his senior leadership colleagues in there to really care for and look after and have those one-to-one conversations, and how that then impacted in terms of improving position equally around sterile services, where to January 2025, sickness was at 13%, come right down to just over 4%. And we can see that improving trend in our welcome back interviews. We're now at 70%. And I think that's a really positive start. And I'm really clear that that's a start, because how we care for our colleagues in a proactive approach to sickness is a shift in our culture, and that will take time to embed. So to assure the board, I was rightly challenged yesterday at the Improvement Board as to, well, performance is going up on welcome backs and we're not seeing the impact of sickness coming down. Are you doing the right thing? And my response was, yes, we are doing the right thing. This is around us holding our course. We know it will impact. We know it will take time to shift cultures and to embed. This shouldn't be seen as an exceptional thing that either I or other colleagues chase after an exec performance meetings or our other forums. This is around it becoming an everyday business as usual, that it's so normal to us that we no longer have to ask about it. And organisationally, I was reminded yesterday there was a time when our mandatory training compliance wasn't as high as it is now, when we were often below it. We put some really focused work in that. We have shifted that. We are above 90% in all of our groups. You will see in the IPR, we know there are 19 individual modules that are below, and we continue to focus that through the performance reviews, and we are, picking that up and working it through. It's the same piece of work around sickness. We have now implemented from January an approach to have a clear reporting process, having an oversight of long-term absence to ensure that there are active plans in place. So I think it's important for the board, bearing in mind we are an outlier. We're an outlier in Greater Manchester. We're an outlier in the NHS nationally in terms of our sickness rates. Equally, we consider the demographics of our local populations and the health inequalities and areas of deprivation. That's very different to some of the areas, for example, in Gloucestershire or the places one might see that we are compared to. But I felt it was important for board to hear the level of scrutiny that either we apply within the organisation through the performance review, or that we hear that I have through the NOP or the improvement groups and the CIP groups. Thank you, Chair.
Thank you. Any other comments or questions? Chris?
Thanks, Chair. I just wanted to say that if you look at the quality aspects of this, of the IPR, just to say to the board that there are a number of issues in there which have got significant variances in them that we've not talked about. I think they're almost all, just looking through it again, I think they are all covered in other papers. So, for example, the obstetric issues, stillbirths and PPHs are covered elsewhere. Some of the things relating to PALS responsiveness is certainly covered by Quality Committee. The one that I don't think we've seen in Quality Committee, and I can't remember us talking about, is the watch metric on the number of significant risks of 16 and above. And suspect that's a combination of the level of risk in the organisation has become very high, it's very high, but also it may well be that we've got a better process for identifying and classifying risks. So I just felt that was something we hadn't picked up on. I can't remember talking about that at quality committee either. So I can't remember it at auditing.
Not in recent months.
No.
I think it's kind of one where that foundation is being put back in.
Yeah,
The BAP, and as it would come forward.
because the data here shows a drop in the number of significant risks and then a rise in recent months. So I thought that was
We have got more focus on risk management at the moment, so I do expect there's going to be a little bit of movement up and down. We've had, I think, 3 meetings of our operational risk group. We've got one of the executive risk group coming up. I do think we're just going to see, I think we'll continue to see some change in that over time, which might not necessarily reflect, and this is going to be quite difficult, isn't it? Might not necessarily reflect a level in the change of risk. It might reflect a level in the management of risk, or indeed just the governance of risk management. So, perhaps then we could just make sure that we put a narrative in there which explains whether this is an increase in the level of risk, whether this is an increase in the improvement of the management of risk. So I think we can probably
the calibration
Yeah.
divisions are going to do to CLM.
Yeah.
Okay, thank you for that, Tim.
Probably doesn't answer your direct question, Chris, but an extension to what Juliet said. You recall that it take an action at audit and risk committee to bring a paper forward in April that described how we manage risk at different levels of the organisation and what the interface between those different levels was. That would give you some degree of assurance, I think, in terms of how we keep control of this and how we sort of level it all out.
I think that'd be helpful too, because at a superficial naive level, if you looked at that, you'd say, well, what's going on here? But I think there's other things that you need to consider.
Okay, thank you for that. Everybody okay with that? Any more questions? Chris, you still got your lights on? Thank you. Okay, so thank you for that, colleagues, and thank you for the linkages into the other assurance reports. I think it's important for colleagues that might be watching this to understand that actually this isn't the only place that we discuss key important quality and performance measures across the organisation, and obviously as Gareth illustrated, real focus around sickness absence, because it plays into so many of our conversations around resources, use of resources, as well as colleagues' well-being and the quality of our leadership, actually. So great to hear that there was a deep dive at the people in the education committee around what some of the opportunities for learning and what others might want to do around. So thank you for that. Okay, so we are being asked to receive the performance report along with the assurances and further improvement actions reported in the board committee summary reports. Are you happy to do that? Thank you. Okay, colleagues, let's move on then to the change portfolio board. So we've got 2 parts here. We've got the update from the meeting and then the assurance report and the reasons hopefully join us. So Louise can take us through the second part. Thank you.
Thank you. I think plus the January and February reports before us, 12.1A, 12.1B, it's continuing to highlight the progress that's been made across our major change programmes. But there are some sort of important differences in terms of levels of assurance and programme risk and organisational readiness. In January, the board reported no red alerts, which is actually quite unusual for all the time I think that we've been doing this piece of work, and that the risk was largely contained at that moment in time, with progress had been made against the medical workforce programme, particularly with the sort of new value shift model work that we were looking to undertake. And there was progress in respect to the clinical leadership model, which at that time we got through the consultation with phase, but we were preparing for recruitment in January. And there was also maturing plans around, for example, Project Unify in respect of adult social care, pathology collaboration, albeit highlighted, particularly in respect of pathology, some complexities around governance and perhaps wanting more in terms of some of the financial benefits that we'd be looking to realise. But then in February, there's kind of a contrast from what we see in January. So particularly in respect of our overall financial sustainability plan and the corporate FSP work streams, which were highlighted as red assurance status, particularly due to insufficient recurrent benefit identification, which again is a thing that we should all be aware of. Some gaps in ownership as well that we've wanted to work through. That said, there was still good progress being reported in respect of the clinical leadership model and also in respect of the EPR, but there's still concerns about ability to remain strategically focused to make sure that we've got community capacity and that we really, and we just talked a little bit here about where some of the system dependencies are. I'll get into Jenny to outline an example of something that strands many areas. So that dependency point is quite important. I think the key thing about the shifts from January to February is kind of reflecting sort of the ongoing challenge we've got around financial recovery and portfolio deliverability across the base. And I think potentially, not potentially, in fact, that we've taken a more cautious stance on portfolio level risk, and that was culminated in this increase in the BAF risk identified. So apart from there, bear in mind that Louise has got a second part. I'm happy to take any questions on that January, February effect. And also he's talked about the audit committee papers as well, about we did do the deep dive as well during that period in respect of the audit committee as well.
Okay, brilliant. Thank you for that. Suzanne.
Thank you, Chair. Just in relation to the red alert risk in the second update in relation to the FSP, and I know board are aware of this, but the original timeframe we were working to was the 4th of February, which aligned to the medium-term plan submission date, and you can't finalise one without the other because there are dependencies between the two documents. We are anticipating the final set of submissions for the planning round to be mid-March, and therefore we would expect that our FSP will finalise following that document submission. So some of these things become beyond our influence when we're trying to make sure that they align to a national process. That's the sort of rationale behind why we've seen some delays on FSP.
Okay, thank you. That's helpful. Any comments or questions on either January or February's update on change protocol? No, so that's for us to note. Thank you, colleagues. Thanks, Zoe. Louise.
So I'll introduce the portfolio assurance report, so item 12.2. If I just draw out 3 key points to note. Firstly, just in terms of the format of the report and in particular the scope of the portfolio. So slide 6 of 40 of the report, where we can see the scope and visual. It's just to note that we've added outpatients, length of stay and theatres programmes in there, and that's to show the pipeline programmes emerging from the 26-27 financial sustainability plan, and they'll be formally included in the scope once that FSP has been finalised. Secondly, we've also added an additional assurance rating into the individual programme slides, and that's for the financial sustainability programmes themselves. That's to show progress being made against the FSP targets for 26-27, so a little bit of a look ahead. Just bearing in mind that the assurance picture that we're providing there for the FSP programmes is based on 25-26 as we currently stand. So it's just a little bit of a look ahead in terms of assurance against that target for 26-27, which at the time of the report was about 50% of that target identified. And then thirdly, in terms of assurance, the development of the FSP itself as a product, I guess, as a document that commenced in January. We've already made reference to it there, so that the number of programmes being assured actually increased from 10 to 11 since the last report to board, which was the December portfolio assurance report. So as usual, we've got the graph showing the trend in the overall governance and delivery assurance ratings in there in slide 12 and the dashboard in slide 13. And any programmes with the red right ratings were drawn out in the February summary report. So as we've already discussed, the financial sustainability plan and the corporate FSP programmes there.
Okay, thanks Louise. Any questions or comments? It's probably worth noting as well that obviously Jeff observes the change portfolio board as one of our non-exec directors, but we've also agreed another non-exec director, so Chris is going to join the change portfolio board as well, so that there's a further opportunity to particularly for non-exec colleagues to think about some of the programme of improvements. Any comments or questions? Really comprehensive report anyway. So that's for us to receive the assurance report and the update around assurance status of the 11 programmes, to support the approach to programme assurance, and also any actions that might be required from senior responsible owners, which I don't have noted any today, but obviously we're in the change portfolio board. I'm guessing that when Rachel made the point earlier around the learning around some of the things that we might want to approach in terms of CQC, you might be referencing some of the approach to change portfolio read across into that improvement work, which might give the assurance that Aziz was suggesting we were missing in terms of 2022 to now. Juliet.
I think one of the pieces of work that's just still in development is around, we would close down the piece of work around maternity safety improvement. We're opening a piece of work around the experience of people who use maternity services and the experience of staff working those services. That's just been scoped out at the minute, but it's specifically been scoped out with the intention of learning and improving within those services, but that being adopted across other services. So kind of in some of these where it's very quality focus that we're building in the specific reference about sharing.
And Tim and I heard a little bit more about that when we observed in the team meeting for maternity and went on walk around. So I heard a little bit more about that, which sounded really interesting work. So looking forward to hearing them. Okay, thank you, colleagues. Thanks, Louise. I'm going to suggest that we. Oh, sorry. Yes, yeah, go ahead. Okay, colleagues, I'm going to carry on for a little while longer if that's okay. Normally we take a break at 11:35, so we might be able to. We're ahead of time, which is an unusual position for us to be in. So we carry on for a little while longer if that's okay. Is that okay with you, Andrew? I know you need. Oh, you're going to disappear. All right, thank you for joining us, and we appreciate it. Okay, so let's move on then to the finance and performance report. So again, two elements to this. We've got the assurance update from January and February. Yeah.
That's Jeff. Yeah, two meetings to report back on. First on the 28th of January was dominated by consideration of our submission of a 3-year plan that support managing NHS England. The key question before us was to submit a compliant for the plan. Compliant, as you know from our discussions, by achieving all of our performance targets for waiting lists, A&E and cancer, and also to achieve financial balance with the last two choices of emphasis supporting in years 1 and 2 over each of the habits. The Foreland consultant committee didn't come to a conclusion, but we did then bring in, as you know, to the board that met on the 10th of February. And we on this meeting on our 2 agenda later today. Also, that meeting on the 20th of January, we're just commenting that we saw good progress on the National Recovery Plan which we instituted back in the last year. And that has now got us to a point where we do not need to apply for a cash report this year. The second meeting on 20th of February was more focused on the current year, although we did have a good report looking forward to the impact of changes to our contracts with commissioners. The biggest change there will be the move from block to activity-based contracts. And we noted the significant risk associated with that. That risk will not put to commission this coming financial year. Work to determine the outcome will happen this coming year, and the Finance Reports Committee will closely track that risk and the work and reports here as necessary. There are other changes to contracts in the coming year, particularly around medical supplies. Those risks are understood and mitigated. At that meeting, whilst I said we have avoided the need for cash support this year, we noted that that will not be possible next year. And I think it's important to realise that when we make that application for cash support, don't get all that we need, we may have to look to our own capital resources, and that's a significant risk to our investment in fixed assets, which, of course, is the opposite of what we want to do, but we may be pushing that position. So again, something we want to keep a close track of. Performance gives a really good in-depth review of what's on recurrent achievement targets, waiting list with times, and the work just having impact now in the sprint that Dave mentioned earlier. Because we were though concerned to come back to the longer term, more sustainable aspects of improvements in built treatment, and we will come back to that in the meetings. And we want to include in that more information and performance data on schemes outside of our hospitals to deflect demand, both on urgent care and planned care, including the sort of medical funds. Finally, interesting to note and good to note from that meeting on the 20th of February that the Water Assurance Framework risks the committee is responsible for have seen us get to a point where on two of them, capital and cash, we reduce the risk to the target score of 12. Really good progress. Less good news is that when we see those risks refreshed for next year and beyond, we expect the cash and capital to be highlighted as very significant risks going forward. So far, so very happy to answer any questions on any.
Okay, thank you for that, Jack. Very comprehensive. Any questions or comments? No? We're all assured? Chris?
Yeah, could I just ask you, you referred to the cash risk, which is the top risk identified. But the second one is CIP. Was that something that you got scrutiny, got assurance on? You come back to that through Suzanne's report.
It will be in Suzanne's report, but the committee did look at the SIP as possible at its meeting. Very close in the current year to our target. But it's still a bit more work to be done before year end. Yeah. It's close, not there yet. But yes, we did gain enough assurance that so far we are doing everything we can do.
It's on page 115 there, and the improvement date February around the position at month 10 anyway.
Yeah, 7 to 10.
Anything you wanted to add, Suzanne?
No, I should express my report.
Okay.
This is point as well.
Move on.
Okay. So I don't want to duplicate anything that that's already highlighted in the insurance reports, but for the record, at month 10, we were reporting a year-to-date deficit of 14.9 million. which is marginally ahead of plan. That's 63 million deficit, excluding deficit support funding at this stage. And the most significant movement between last month and this month is that we've concluded conversations with the ICB in relation to ERF funding, and that, as we planned, would also always be something that we feature as part of our mitigations in the last quarter of the year. So we now have accrued and that income started to flow, which is positive. This particular month, month 10, is a really critical one. So as I've explained through board throughout the course of these discussions, the way we profiled our plan towards the back end means this is the most challenging of our quarters. So to achieve our plan of month 10 was a really sort of significant point in maintaining the momentum that Jeff has described in delivery of the financial recovery plan. I always give sort of hot off the press update in relation to month 11. That's due to the timing of this meeting and the paperwork. And we closed down month 11 yesterday, and we've maintained our achievement of month 11, which again, that's two of our most challenging of our quarter. We managed to deliver in line with our financial recovery plan and our position, which again is really positive. So we've only 1 month to go. From a forecast perspective, and we continue to work really hard to make sure that we end the financial year well. We flagged at the last meeting that there was approximately £20 million worth of risk in delivery of our financial position at year end. That's now reduced to 9.6 million in terms of risk, but we do have planned mitigations in place to take us to the end of the year. One of the risks that we've talked about in depth through balance and performance committees around adult social care. We've made some good progress with colleagues at Salford locality and Salford local authority in terms of their commitment towards the adult social care package care. That will need to run through their governance processes as it does in other years. But that's an important part of our ability to deliver our financial requirements. On fit, to Chris's point, so at the time of writing this report, we were still ahead of our cost improvement plan in terms of transacted schemes. So we were delivering 85 million against the 76 million pound target. But we could see that we're catching up there because we've been over delivering on SIP because of the profile of SIP during the course of the year. So it's started to catch itself up. But the cash point is really important, Chris, because if we don't deliver cash releasing, run rate reducing schemes, then that does not help our cash balance. And for the last 6 months, that's why we've been putting all of our energies into making sure that we do make that clear connection between those two things. When we move into the next financial year, it becomes even more critical because we will be wholly reliant on all of our cost improvement opportunities impacting on our run rate and our cash impact. So that's why we put all this effort in this year to make sure that that's clear and we're focusing our efforts and attentions in doing that in a safe way. Just in terms of the recurrent challenge, which Jeff to touch on, as we agreed when we were talking to our plan submissions, the importance of closing down our exit run rate in line with our plan remains a really, really critical part of what we're putting our efforts in. And as I was talking to Tim earlier, until I have a last breath in my body, until the 31st of March at 11:59, we will continue to work really, really hard in closing down the recurrent cost improvement requirement to make sure that we pave the way into the next financial year as best we can. That does not go without the importance of the quality impact assessment process that sits alongside that. But a huge amount of effort is going in that and continues to go into that in the remaining weeks that we have. The last thing I wanted to say before I open any questions, because it was raised in the last board meeting by Joe Gibson, who I know who's on annual leave for this meeting, so not here, was just some questions around the workforce elements of the finance report. We have made some adjustments to the report on the back of Joe's comments, and Gertie and I are working in the background following some feedback from Joe. Jeff, you've also recognised that, you know, how do we play this into the Finance and Performance Committee, but also into the People and Education Committee. One of the things Joe was raising is making sure that there's clarity in all of the different aspects, because there were 3 ways we are looking at particularly temporary spend in this report. We're looking at a plan, which is a budgetary plan, which is fixed We can't change it, even though things might change in the course of the year. We're looking at the actual spend, our run rate, and what direction of travel it is taking. And we're looking at NHS targets, which require us to reduce our bank and agency spend. So bank by 10% and agency by 30%. So that's sort of important that we understand there's 3 different things that we're looking at, which is why there's a slightly different presentation in some of the elements because they're different things. But to circle back to the comments in earlier that Juliet was talking about in relation to temporary staffing spend and our reliance on it, we do have an overperformance and overspend on agency spend that we're reporting. It's not material and we still remain significantly under the national target of 3%. So we're only 0.89% of agency spend, but we're not making the national 30% reduction of, in part because we've done so well and reduced it so significantly. But that just shows that sometimes we can meet the targets, sometimes we kind of don't. However, our bank spend is significant. So at this reporting period, in totality, across both agency and bank, we're spending just over 89 million, 80 million of which is bank related. And we have seen an increase in budgetary terms of about 20 million related to bank. That will be relying on industrial action, which we did not plan for, and there's been quite a few instances of that during the course of the year. Our vacancy cover, our sickness cover, and our enhanced care. The last one continues to reduce. So about 20% of our bank related to that at the start of the year, and that's reduced to about 12%. So it just sort of make the picture of that how we're using it and how some of the other conversations about how we've got the resources there does mean that we need to focus, as Juliet has already pointed out, on substantive recruitment and making sure that we've got the right staff with the right skills to take care of the patient's needs at the time. And that will be, alongside some of what we're doing around things, will help us to reduce that. But just wanted to flag that given the conversation we had at last board meeting.
Thanks for that, Suzanne. Gertie?
Thank you, Chair. I just wanted to add some colour and remind colleagues, if we take us back to before Suzanne joined us, we had a board development session last February. So myself and Craig and Jude and others talked the board through the plan looking forward to next year. And we had a very detailed conversation about the reality was being able to achieve the national agency reduction target in light of the significant amount of work in the preceding 2 years that we've done. And we talked about how we were approximately 42 full-time equivalents in reality of agency staff in February of last year. And a further reduction of that we would obviously seek to deliver, but we recognised it was going to be quite challenging. So just to give that context and remind board colleagues of 42 full-time equivalent of agency work in an organisation of nearly 19,000 full-time equivalents is a significant achievement for us. So there's a bit of, as Suzanne says, we have done a lot of work. We haven't quite hit this one because of the amount of work we've done, but I thought it might be helpful to bring colleagues back to that conversation. I think it was February 25.
Okay, thank you. Any more questions? Okay, so this is for us to obviously receive and update the report, note position and the highlighted risks in the report, as well as the mitigating actions that are included in the report. Are we happy to do that? Okay, thank you. Thanks, Suzanne. Okay, I am going to suggest that we take a break now. Now, our quality committee report, and we've got Craig with us as well, joined us for the meeting to for quality pointers. So we'll just pick up the quality report first, Chris, and then we'll.
Sorry, I'm just moving. Place up must be placed now. Okay. Thanks, Gina. So reporting on the meeting, quality committee meeting on the 16th of February. And as usual, you'll see from the paper a rather long list of issues that we considered, which are listed there. In terms of the items to bring to the board's attention, you see 3 things listed there, which are either the subject of other papers or we've talked about. So 7-day hospital standards. There's a fuller paper that Rafiq will refer to later on. But as you can see, there were concerns about certainly one of the standards, but generally about this issue. And given, I think, Rafiq, it's true to say that this is so core to productivity and a whole range of other issues, that it isn't sort of a purely clinical quality question. This is a sort of almost like a whole organisation question. So I'm sure you'll pick up on that. But in terms of the audit that was done from the committee's point of view, we identified the fact that we were not where we needed to be. Never events, again, Rafiq has referred to this, 10 never events over the last period of 12 months. And it's reported to the committee that the majority of these were wrong site or related to wrong site surgery issues. And I think we heard Rafiq refer to the fact that there's a piece of external advice on that that's been commissioned, so we will receive that in the future. Clearly an important thing in terms of us as a learning organisation. And then maternity, again, Faith is here and will help us, but I'll just make a brief comment that the committee heard that you know, the data that we saw in the quarterly perinatal mortality report did have some concerning issues in it. In terms of postpartum hemorrhage rates, a number of other issues, workforce pressures, but also the rate of stillbirths has continued to be reported as increasing. Now, there are reasons behind that, and what it is true to say is that we get significant assurance on the reviews that are undertaken when those stillbirths take place, and there's some very detailed information provided on the level of care and the issue of whether there are any defects in care which could have made it for a happier outcome in these very sad cases. What was particularly concerning, and again, I'm sure we'll come back to this, but I think I'm right in saying, Faith, that the concerning thing there is that in recent months there have been one or possibly two stillbirths which were term, as opposed to being very small premature babies, which is always a tragedy, of course. But when it's babies that are at term or about, that is a particular concern. So I think that's something that we've flagged alerts, and as you see, we've got processes for monitoring. There was a further discussion about BAF risks, and I think Jeff referred to earlier the fact that in terms of resetting the BAF, both for a sort of multi-year forward view, but also in terms of assessments of the level of risk in the organisation, the risk to those strategic objectives, then there's a piece of work that is being done to just recalibrate those and be realistic. I think Juliet would be right in saying around what we think is actually the target risk and what's our actual risk appetite and what's actually achievable in terms of the mitigation. And these are not easy balances to make sometimes, but we hope we've got a piece of work in place there. We talked about other things. A couple of things just on assurance. The radiation protection report, I think, gave us assurance. For me, that's an important issue. It's and we had compliance with the regulatory requirements, which was confirmed there, and two processes which are now in place which weren't previously. One is the Quality Safety Management Group, which we talked about before, and whilst it had only met once by the time this quality committee took place, so we only had a very provisional report, I think it showed that that was in place already, so we were able to focus as a result of that. And then also the operational risk management structures, which are referred to under Assure in the report, which I would say are reflected in the earlier conversation about the level of the numbers of extreme risks which we're identifying, which I'm sure we'll come back to, but it seems to me we've got a much better process in place now to identify and calibrate those risks. We have, following on from that, in the appendix, there's a timeline that Caroline Greenhouse has put in on the CQC that we've talked about that in detail already with Juliet, so I probably don't need to dwell on that. Faith has got a report which is really on behalf of the Quality Committee, which confirms that we have done our duty and scrutinised as is required by the maternity incentive scheme, but actually by common sense it's required for us to scrutinise the maternity data, the quarterly maternity data in some detail. And then we had that opportunity. And then also there's a paper that Rafika's got, which again we saw in scrutinised in some detail of the committee on 7-day services. So I think those are the things I wanted to draw to the board's attention.
Okay, thank you, Chris. Any comments or questions? The February. Aziz?
Yeah, I mean, I know Faith is here, so I'm going to preempt what Faith said with this concern about stillbirths and postpartum hemorrhages, because postpartum hemorrhages doubled in a really short period of time, and stillbirths, we had really low stillbirth rate. There was all this tension, all working, and it was around 3 for about 6, 8, 9 months, and it jumped in April 25, and it's doubled, nearly doubled from over 3 per month per thousand to 6 per thousand in just over 6 months. Now, when you add those two things together and then look at the report on staffing and 20% below what should be, we did scrutinise this at the Quality Committee. It's important that you know that we had a really long conversation about it, and each one of those is examined. It's externally examined as well. So you're not just taking our team's word for it. People outside are looking at this. But there's something really uncomfortable about a doubling in 6 months of stillbirth rates and of these postpartum hemorrhage in an even shorter period, and it just made us really deeply uncomfortable actually, and I just wanted to preface this report by saying that was a long and kind of complicated discussion really at Quality Committee.
Okay, we'll come to the report shortly, unless it seems anything else I want to pick up in general around quality on the report before I come to Ben, because you might have some views on why that is. Certainly we had an external report on the stillbirths that bit back to Quality Committee, Chris.
Yes. Yeah. The other thing just to say on before we get to the detail thing, Aziz is right. These are some of the concern things. The other thing to say about assurance.
Chris, just pop your mic.
I'm sorry. The other thing to say about assurance for on the subject of maternity is we have the role of maternity champion, so we've got Tim who undertakes that role, but also there's the I always get it wrong, the LMNS, the local maternity network, who we've heard from previously, and who provide that level of assurance that the right things are being done. I mean, you're always stressed, aren't you, because you're talking here about where things have not been gone right, and that's almost tragic. But we've got that additional assurance that the right things are being done. So I think it's in that context.
Okay, thank you. We're still on the general quality reports, not moved yet into the maternity report. Well, definitely that issue. Juliet?
Not on the general quality report, just on that point. I think there's an important distinction to be made, and I think Chris has partially made, but I just want to clarify what Aziz is asking. Whilst it's uncomfortable to hear about harm, it is, whatever that harm is, it at the end of the first section, Had we be clear that we've had the assurance that we're required, please, because I think they're different. And I think you started your point out as is with a change in statistics, which might want us to look somewhere because it feels uncomfortable. I think as long as when we get to the end of this, we're assured that Faith has given us what we need in terms of assurance that this is being appropriately managed. I just
and that was the view. That was the view of the committee. That
It was, yes.
Yeah.
I'm just saying we had I want everyone to know that we really talked a lot about this, and there was a lot of scrutiny in the committee.
Yeah.
As you would expect, and as you would hope.
No, thank you for that. Okay, so before we move on to maternity, I know we're definitely so all the questions have been about that so far, but anything else on the general quality or Owen?
Yeah, really, it was just a question about whether you thought we've got a real line of sight around the 24, not the 7-day standard 8. It seems to be something that we won't be clear and I'm conscious that we'll be discussions about it, but I just wanted to get your flavour as medical director about where you thought we were at on that.
So in short, we're not in a good place. That is detailed in the paper around 7-day services. It has impact on multiple things as respecting quality of care and because we can see now it is impacted. This, what I was going to say later, is going to be tied into the work of value shift, etc. To basically say we need to identify exactly what we need to deliver for 7-day services per specialty, and use some of the reshaping work that we're doing through the medical workforce program to allocate some of the resource that currently isn't best used to achieve some of this.
And I think that point speaks to some of the conversation we'll have about flow as well later on as well, because I think intrinsically linked to that too. Okay, thank you. Any other comments or questions, Chris?
Just to complete the recommendations in the report, there's a recommendation on that issue that people an education committee take an interest in this issue. I wouldn't want that. When I've looked again at the word here, I wouldn't want that to be read as the quality committee will not be continuing to do its annual review of this specific thing. But there are some people issues that in there which we thought people committee should be taking assurance on. So just to be clear about it.
Sure. Yes. I've not got the recommendations yet, but the have you? I know you won't be continuing this, Aziz, but you will go to view on happy to pick up that oversight that's being requested of the staffing model for 7 days.
Yeah, if I could, Chair, I think there's absolutely some people elements that the People and Education Committee would want to receive assurance on around the 7-day services. However, I think we should perhaps nuance the request around it would either be the People and Education Committee in terms of assurance or another appropriate committee, for example, the Trust Leadership Group that we've proposed to the new establishment, because People Committee are not a decision-making forum, whereas if we need to make investment decisions, that would have to go through Trust Leadership Group.
That's why I refer to assurance being taken by the assurance committee.
Okay, so should we?
I think if I come back briefly on that, what I would propose, Chair, is a lot of these standards essentially are needing to be delivered via the medical workforce. And one of the very first things that we task our new medical directors under the guidance of managing directors and us is to think through, identify, we have an audit, think through what a plan to rectify this would look like. And I would foresee that we will start to work on something like that at the end of Q1 in the year. So what I would propose is we will articulate a plan because it's the workforce, and we will propose to colleagues where I would suggest that this will receive, because there may well be constituent parts that need to be seen.
Okay, so in terms of the recommendations, then are we on the further update on where that will be, where the oversight will be? Yes. Thank you for that. Okay, so if there's nothing else on the quality report, there's a couple of recommendations. So we're being asked to know the contents. Oh, sorry. Repeat.
I just switched off.
So we've been asked to note the contents of the report, continue to support the work of the committee, which of course we do, and support the decision to move the oversight, but we'll come back to where that might be when we've got an idea of the action plan around that. And it might be that it's the improvement that Gertie suggested, because that would seem to make sense. Okay, thank you for that. So let's move on then to the perinatal quality surveillance report. And thank you for coming to join us. Is there anything you wanted to pull out in terms of the report for our attention?
No, just some key areas, Chair, some of which have already been highlighted. So particularly around our stillbirths, and as described, we had an in-depth conversation and discussion and scrutiny around that at the Quality Committee. The driving factor and our last kind of flag for our stillbirths occurred in April 25, when we had 6 stillbirths that occurred, and as you quite rightly said, they were reviewed as part of the cluster review by the LMNS. Our target for the LMNS for this year for our stillbirths, based on historical kind of themes, is 3.68%. So we are currently running above the target that we would expect for our stillbirth rates. And I think it is important that the board are cited on that, and that we do have robust processes in place to assure ourselves that if we have done anything that has been causal to that stillbirth, that we've taken appropriate review and action to prevent reoccurrence. We have also noted that, as Chris has said, we have seen an increase in our term stillbirths, and again, that's very relevant. But what also provides us additional assurances now, we've got the MOS system, so the signal system that was introduced in November, December time, where if particular stillbirths are occurring in organisations such as term stillbirths, there is also an external flag. And an external scrutiny of reports that have to be written and go back to NHS England. And again, that gives us the opportunity to review internally, but also to have that external review in terms of, is there anything that we could have done differently for that particular family? What is worth noting is that the majority of ladies at term do present via our triage department with initially reduced fetal movements, and then the stillbirth is confirmed. And we are compliant with the regional guidance in terms of following the correct pathways for those women. What is worth noting is that one of our term stillbirths, there was a breach in guidelines. I think it's really important that we differentiate between where we've caused harm and when we feel that we haven't caused harm. So there was one stillbirth in this quarter that was causal. Action has been taken, and appropriate review is also happening externally through MNSI. So again, internal review and external review to demonstrate any learning. We have completed and submitted our MIS declaration for year 7, and those of you that were at board last time are aware that we reported 9 out of 10, with the hope that our small misdemeanour will be upgraded to 10 out of 10. We have also seen the publication of the requirements for year 8 for MIS, and again, I think that's been shared with you within these papers. It does look significantly different. There are actually now only 6 safety actions, but that doesn't mean any less of work. They're just changing the way in which we are expected to report. Again, what's really important is that there is that increase around board accountability. And if you read the document, you'll see kind of where that starts to come through in terms of oversight of maternity and neonatal support, which I'm very assured that we have really good support and oversight from a board perspective within this organisation for our maternity and neonatal services. Just a couple of things to pull out around some of the quality aspects and patient experience. So you'll note that I've made particular reference to triage within this paper. And you can see the volume of women's attendances at triage that are fairly consistent. The team do an absolutely excellent job in ensuring safety of women in our department in terms of that early triage within 15 minutes to identify risk. what we're currently struggling with within the service is that obstetric review to follow that initial risk assessment and ongoing care. So we have had a significant number of incidents reported where there have been delays in that obstetric review, and also that triangulates with some of our CQC maternity survey data and our FFT data. So it is important that we really pay focus to that obstetric review. And we're currently looking with the rest of the senior leadership team around an options appraisal as to how we put more in to that obstetric staffing to ensure that we've got that appropriate cover and safety for our women accessing triage. I've also mentioned the work that's been done over the last month in terms of our Maternity Voices partnership. And again, it's important that we are triangulating all of our feedback, and the feedback through that triangulation is demonstrating some key areas that we're focusing on within the organisation, and those are delays in antenatal clinics, delays in planned elective procedures due to competing demands and capacity, and also those delays in triage. So they're the real areas of focus within the service. And we have seen, I've just recently received an email this morning that our FFT for February is much better than it has been historically. So that does bode well for the next CQC maternity service, where they will survey women that birth in this month in February. So that does paint a more positive picture of women's experiences currently within maternity services. And we're seeing that through leadership walk rounds and speaking to women and families in situ in real time. So in conclusion, I think it's important that the board, as I say, are aware of the rises in some of our matrix. They're not currently flagging within the LMNS. I had my monthly data meeting yesterday with the LMNS, and none of our safety metrics are currently flagging as areas of concern. But it's important that we do continue that sight on them and continue to demonstrate that level of rigour and complexity around the women that we are caring for.
Thank you for that. That's really helpful. Thank you, Faith, and good to see that we're getting the improvements in terms of the FFT as well. That's more up to date, because that's almost a year of data now, isn't it? The data, not that it's not helpful feedback for us in terms of learning, but it's great to get a good up to date picture as well. So colleagues, I have Rafiq.
Thank you, Chair. So one quick comment and then a question. The comment relates to 211 in the paper. It's interesting sort of rereading some of this. I just want to tie this to the discussion we just had around 7-day services and access to senior decision making. So again, that will be part of that review. And there's an interesting statement in there about potentially requiring increased budget for medical cover. It could possibly, but what we've seen consistently, and gynecology, where there's an overlap, is on our list. We have quite significant extra contractual spend in particular areas, which reflects that our baseline substantive workforce not quite well. That happens there potentially gets us to where we need to without necessarily increased budget. So that's my comment. The question I had was on 2.8.1, which I picked up this time, and it's about the study being at 5%. The reason I picked up on it is we have some issues with how we're governing study leave, certainly in the medical space. 5% is pretty high, and we should have some control as to how many colleagues are going to on study leave when. So I'm just curious, because it's not something I really thought through and connected.
Yeah, thanks, Rafiq. So the study leave is purely for mandatory study leave. So this is the requirements of training for midwives, obstetricians, anaesthetists, all professionals working within maternity services. So this includes your CTG training, your prompt, etc. So this is what we would need to deliver to be compliant with the maternity incentive scheme. Anything over and above that isn't counted within this 5%.
Just maybe could come back to that and we can discuss in a bit more detail. But again, it just feels to me that you might challenge this, that maybe our establishments are not taking this into account as well. So, again, so just to see. Thank you.
Okay, thank you for that. Owen?
Yeah, just in respect to the big point made about the friends and family test, I just wondered what that looks like from a Black and Asian women perspective.
So our FFT data doesn't break that down as far as I'm aware currently. We just get the data per area. I think what we need to focus on, Owen, is continuing to speak to women in real time as well as FFT. We're getting an awful lot of intelligence from speaking to our women in situ about their experiences. And what was really refreshing is recently when we did a walk around with Tim and with Natalie from our MMVP, they did some real-time feedbacks with women, and there was absolutely no hesitation in getting an interpreter to support that feedback from women whose first language wasn't English. So we're absolutely in a rhythm now where communication with all of our women is important, and the use of interpreters is first line. Nobody hesitates about getting an interpreter. What we do know from the FFT platform is that women can access it in different languages, and that is how you can input the information, and it is in different languages, but we don't get it out the other side in terms of diversity. It's just a number of women that have completed the FFT. So that isn't something that we have available to us.
Just wonder whether we need to consider something bespoke then, because we know from the CQC survey, we know, don't we? There's a cohort of people that absolutely like a real-time feedback scenario, but just because FFT maybe doesn't do it, maybe we might just need to consider that.
Yeah.
I'm not saying we must, but I just like to know we have.
No, it's important, isn't it, to make sure that all of our feedback is, you know, meets the needs of our women, but also that it's representative of our population. But I do feel as somebody that does the real-time feedbacks with staff and having observed them, that they do seek feedback from all women, and they don't just take an option of just seeking feedback from women who speak English, because that's potentially an easier option.
I mean, I think some of the work that's happening around the further phases, part of the change portfolio board work, will be really delving into some of the skull, because even the FFT is only kind of the end of the line type of feedback, and we know that community services, for example, and antenatal services, we need to understand why some women choose not to book with us early, and their experience might be very different in the community than we would have in certain cohorts of our population, which wouldn't be okay.
And it's really important that the MNVP, and you'll see within the paper, are linking in with women in community settings as well, not just in the hospital setting. So the MNVPs have been attending some of our pregnancy circles, particularly the ones that are targeted at our Urdu-speaking women. So we bring a group of Urdu-speaking women together with an interpreter and run a pregnancy circle. So they all have a common language, they have a common population, they build a community. And the MNVP attending those sessions and getting that feedback from that group of women again has been really, really successful.
Great, thank you very much. Okay, Julia.
Thank you, Chair. It's worth pointing out that the survey results did get attention from the ICB and from the region. They prepared a similar set of slides to the ones that we've got in the board pack, which went to Quality Improvement Group for Region and QSAM for the ICB. We did get really good feedback there on the work. We did get that, the lady's name from ICB, who said she'd been meeting with Faith and the team, and they were getting assurance that they required that the improvements were being made, that we were taking the results seriously, and the fact that the team were disappointed to get those results. So I just think perhaps we need to modify what's coming through here slightly to Faith in putting the work in there specifically around experience and the work that you have been doing around looking at experiences of women from different ethnic backgrounds, but also language as well. So I think we can probably see some of that work coming through, which I do think is becoming a more important feature of the national work, which is the experience of women, particularly women from a Black ethnic background, in terms of their outcomes. So, and I know you have been looking at that first, so I just think it's probably not coming through on the report, probably Owen, in the way that you were asking as well, but the work is, some of the work's going on. I just think we're not seeing it, but I do think it's important that we do see it here. So maybe just have a quarterly focus on some of that in here, so we're getting assurance that we need around the experience when we know that access to services, experience of services do link to outcomes. So we can see some more of that work coming through.
And I'd just like to also say, we have been supported by Juliet, which has been great, to recruit a senior leader whose specific focus in maternity is going to be around the E&E strategy. So it's really important that they will start to bring all of that work together, but also be able to put some narrative behind the work that's being done. But what does that mean, and how is it improving outcomes? Because I think what we've done is we've done an awful lot of work, but what we've not been able to do is capture what difference is it making, and what do we need to do more of, and what do we need to do less of for our women.
Great, thank you for that. Chris?
Sort of going back slightly, but just draw attention to the requirement in the NIS scheme for cross-professional workforce planning and also working. And I think in the discussions that we have at Quality Committee, that comes out to me as a constant theme, and you picked a bit up of it, I think. But things like making sure that our posts are attractive to people so that we're not reliant on locums. We are able to, I think these are some of the things which have been discussed through Quality Committee, but actually it's worth emphasising to the board, both in terms of compliance here, but in addressing those PPH rates, getting the right people into the job is crucial. I'm sure that's part of the CRM and other processes, but I don't know if it was.
Yeah, no, that would be really helpful, and if you're picking that up as an area of focus, because certainly we know that we've got some long-term locums that have been with us for some time, which is positive in some ways, but then obviously it's a question of why what that is, I guess. Do you want to come back?
Just to say that it is a slightly complex picture. So we have a long-term project that's on the medical workforce, essentially looking at where we have them, why we have them, etc. Everybody would recognise, and we have seen that when we have our own substantive colleagues, we have consistent colleagues that we work with, and that impacts quality. We do sometimes, and there is an overlap between those two things. Some colleagues are consistently for a long time, but not a temporary sort of in-out workers. Some of them have been with us. That's part of the problem. Some of them have been with us years. And we need to sort of rectify, if you like, how they're trained in the organisation. But we also have locums who dip in and out, and it's just about quality colleagues who are delivering consistently.
Yeah, and effectively, efficiently. Yeah. Any other comments or questions, colleagues? Okay, I think Julia asked a question earlier about whether or not there's any gaps in our assurance at the end of our conversation around this. Is there anything that colleagues wanted to highlight that still feels like it's a gap in terms of assurance? No?
It just, well, just in terms of the BAF risk, we always agonise about this, don't we? Because on the one hand, we are assured. On the other hand, we feel that it's an area of high risk. So the BAF risk is what is as it is, but I just make, in terms of assurance, that's where we probably land, that we haven't changed it, although I feel that we could probably reduce that risk, but we're always very reluctant to do so.
Okay.
I mean, we did change it, didn't we? We have reduced it.
Yeah.
But I think so.
Yeah.
We have just for
it is what it is. It is
clarification. We did reduce it following all of the safety work that was done. I think we considered it, didn't when we felt that because of the work that we're doing around looking further in detail, experience and impact and outcomes, that we felt that we should keep it where it is because we recognise the additional work to do, and I think that's reflected in the work.
Because it's brought here, but in terms of the assurance that we have, it's to hand, you know, to hand.
And those areas of focus are reflected in the mitigating actions as well.
Yeah.
Okay, thank you. Rachel.
There has been a report published about findings to do with, in line with Owen's point earlier, disproportionate harm caused to women from Black, African, Caribbean backgrounds, irrespective of language. And I do wonder if we are assured around that at the moment. Probably, I would say we have some aspects that we're looking at external review, but I'm not sure if they get to that granular level where we can confidently say that there's the same outcomes for everybody. I do just wonder if.
We could say that there aren't.
Yeah. So I at the moment, I'm not sure and I do wonder if we need to, sorry, Owen.
No, just talk about time.
Talk about learning, I've not learned.
No. I just wonder if there's some linkage we can make here to our population health consultancy work and if there's a lens that we need to apply here, really.
I think that's the work that Faith mentioned around, and it's part of the change of board oversight. So we have a strand now, which is clearly focused on, and recruited a new team member who's focused on that. And that's for that very reason that, you know, there is differential outcomes for women from different backgrounds that wouldn't be acceptable to us in terms of an outcome. So it's not positive.
No.
And we need to understand why that is. And some of that can be related to people booking quite late with us, and we need to understand why is that. Because that obviously has got a real correlation to the harm that people experience as a result. So I guess
the gap in assurance for me is not that we're not looking at, I think we are, but we don't necessarily know exactly why. And we perhaps don't have a plan in place to do something about it.
I think we probably do. I guess I would say our assurance mechanisms are that we've put in place something to explore that, to understand that better, and then bring back with a plan of action. But I don't think we can say we are comfortable with where that currently operates.
Agreed.
But I think the assurance mechanisms to explore that feel like they're in place. Juliet, do you want to add anything?
I think it's the clarity, isn't it? So we know that the evidence says that outcomes are different based upon your people from a Black minority background. But we're recognising that and we're putting in the work to do that. That's the assurance that you're getting. But we're not saying that we've got outcomes that are equal amongst all people.
Yeah. Okay. You can go with that, Rachel.
Yeah, I just think it's important as a board that even if we are assured that we express, which you absolutely have, that we are not comfortable with our current position, and I think we have expressed that we want to do more. But yeah, thank you.
Yeah, I think it's worth kind of. I mean, the board has been briefed on the work that Christine Camacho has been doing, so that's been part of a board development there. So we have seen that. There's kind of work going on late booking and kind of the analysis on ethnicity and geography that's being done. It's work on gestational diabetes. So there's quite a raft of work. And that conversation kind of suggests perhaps it would be good at some point for the board to be further briefed on that. But just not being aware of the health inequalities work.
I mean, I think now some of that will get fed back through the change of portfolio, because it's got a very specific lens around health inequalities. But I think more generally around health inequalities is probably something that we are looking at in terms of a board session. So we will definitely pick that up. Thank you. Okay, thank you. So I'm going to take us back to the recommendation. So the first is to receive the update from the Quality Committee. And also to know that it's under delegated authority that recognises maternity and neonatal safety, but we've also scrutinised it here as well, which is absolutely right. Everybody comfortable with that? Okay, thank you, Faye. Thanks for joining us again. Appreciate it. Okay, I'm going to move us on quickly now to the 7-day services annual assessment. We've already touched on it already, with one recommendation at least that we're going to pick up some further oversight of that and the action plan. Is there anything else you want to say in relation to the 7-day insurance report?
Yeah, but very briefly, Chair, we touched on some detail, just things I would like to highlight to colleagues so that everybody's aware. Is first, as part of our contractual arrangement, we should be seeking assurance by the board of our 7-day services situation. We haven't been doing that consistently, so this is the start of ensuring that we are doing that in consistent cycles. So we'll ensure that, as discussed, this is about ensuring that our patients have equitable quality care, but also has significant impact on things like load and our performance. What has happened is essentially there has been a disconnect between how we job plan medical colleagues and the actual service needs, service design, etc. Happening in parallel and didn't quite meet. And interestingly, so when we looked at this historically, this is one of the things that when I came to the organization took me a while to get my head around, because the solution to that had been consistently just essentially to change rotas and then cover them, especially the out of hours, with some sort of additionality, either through external colleagues or additional on internal colleagues. So that has impact on our spend, our bank spend, our agency spend, which we need to get to the bottom of. Just a short thing about what the standards are. So there's a whole host of 7-day standards because pretty much no trust in the UK, very few meeting them. There was a focus on what are the priority standards, and those are the ones you see here. That's why the numbering is a bit whack. So 2, 5, and 8 essentially as the standards that we are looking at. As by consultants, as the senior decision maker, seeing patients at a reasonable time, 14 hours. So if somebody comes in line, they can be seen in the following day. It's about consulting patients having access to essentially consultant-led diagnostics and interventions 7 days a week, reasonable, and a daily review of any patient who comes in as an emergency. Touches on to some of our CQC things which we discussed. So just I think worth being aware of that. As we've said, sort of links with multiple things: quality, generally quality, specifically CQC, our medical workforce, our value shift program, and GIRFT is, as you see, one of the recommendations that we stick to. GIRFT recommendations also touches a little bit on EPR. So if you who were curious and looked at the audit, you'll find that the numbers are relatively small. In an EPR-driven world, EPR, we would be able to more consistently audit this much easier, much more reliable data. And as I said, we will put together a plan and suggest to colleagues how that should be overseen for colleagues to agree. And the only other thing I was going to add is, just because we discussed it before, SAMBA is an acronym, and that's the Society of Acute Medicine Benchmarking. To refresh my memory, it could be one word again, but so that's what SAMBA is, and we will make sure that the members that we bring in the future don't fall into that trap. Thank you, and happy to take the actions.
Thank you, Rafi, that's helpful. And is there a reason why we've not reported Salford's compliance against clinical standard 2? We did for every other charter, but we just said Salford it had improved year on year.
There is it's put somewhere if you look into the depths of Roger's put it explicitly in the paper, so it has risen to the 40%. But I'm just trying to find what the number was before. So way below should be in terms of compliance, especially for a site like Salford that is heavily acute, very busy, tertiary services. That I think some of what we're seeing here, I think, is links to some of the challenges that we are consistently discussing. I don't think it's by chance that when you look at Salford compliance being some of our lowest in terms of the mismatch with the acuity of the services, but those are the sites where we struggle much with things like that.
Okay, Thank you. Leah.
Thank you. Thanks, Rafiq. I think it's just impact flow. This is flow because we know when we've had periods of industrial action and we've had senior decision makers, we have flow, and therefore the standards in there are really essential because both in the diagnostics we've measured whether we do less tests during industrial action, and that's why we do things quicker, but we don't do less tests. We've looked at that. What we do is make decisions, and without these decisions, we can put as many kind of our wraparound services to that, but we won't get the flow if somebody hasn't made a decision for the patient. So I just think it's a really essential piece of work, and what support can we give to making this kind of the forefront of what we need to do to improve flow.
Okay, thanks, Leah. Any other comments or questions? Juliet, and then please.
It is I know Rafiq, you refer to the connection to the CQC, the recent CQC inspections, but it's absolutely integrated into there, isn't it? That we don't get access to all of the medical oversight that we need for the patients. So it is important to triangulate that. I think the work that we're doing around bed reconfiguration will help as well, because we'll have patients. So it will be easy for medical colleagues to spend more time with the patients, because the patients will be in the right places as well. So some of that work will help with overall efficiency and utilisation of that. Important as well. Thank you.
Okay, thanks, Julia. Aziz?
I just wanted to ask Rafiq, I'm not sure if you were at People Committee, but our alert was on medical job plans. Is this the same thing? Because diagnostics and pharmacy were the people who were sitting in front of us at the last People Committee, and they have a 96% job plan completion rate compared to the NTA, which was 24%. And we kind of said, well, why is that? And that you were there actually, and Dan said they'd bring a report back to explain that. Is this the same thing?
So if I tackle that one first, NCA rate is not 24%, it's 70-something%. But diagnostics pharmacy is our best, and it's 96%. When I joined the organisation, we were at 34%. Then the second year, we were at 50-something, and our most recent year, the exact number was sort of 76, 70, some hovering around here.
Okay, well, we were mistaken the data that we were given then, because as you would expect, we kind of went, how could it be 24%?
So I'll go back and check, because I think I know when that was, because I was away, so I didn't see that thing, but I will check that later. But to answer the core question, which is this the same thing? It is related, right? So the data that we will have seen at the committee is our overall job planning data, which it is very difficult to plan for our medical workers if we don't understand how they're using the time. So when we were at 34%, that is useless data. So we're much nearer where we need to be, and our target for coming cycle is 95% across the organisation, so that we can use that reliably. So it is about job planning, but it's not only about job planning. Other points, absolutely, this would be a collective support. I think that the switch to led arrangement across the organisation will help, but ultimately this is about a multi-professional team coming together to plan things properly and ensure that planning goes into job planning. And the final point, quality, just to highlight to colleagues, there's two angles. One of them is this impacts the quality of care we're giving to patients, as Julia has highlighted, but also as part of our well-led arrangements. The CQC could also be exploring, are we discussing some of the services at the which is.
Okay, thank you. Chris?
Yeah, just a bit on that theme, Rafiq. You said it's not just about job planning. Said that several times as well. Have we recognised sufficiently the significance of the change to 7-day services? The temptation is to say it's about some job plans. But have we recognised collectively the significance of this? Because I suspect it's a big cultural change in terms of
way an organisation works.
So who we define we as a board. I would emphasize to the board that this is key to us delivering quality services in a modern care setting. If you think about what essentially what we're saying is we have today 26 patients in our hospitals who have come in for something serious, some emergency, something rather, who over the weekend will not be seen by a senior decision maker. So flow aside, the planning and the quality of care that individual patient is getting will not be optimal. You know, we employ our consultants for a reason. And so this is not the right way to be delivering healthcare in 2026. And so if it hasn't come across, I want to emphasize it because I think that's a very valid point. But what we will now be doing is starting to have the right conversations with our leadership in the reshaped organization, essentially say, this is one of our priorities, how are we going to get it?
Was that, I kind of heard that, you know, I don't doubt your commitment to that. I suppose it's what's our confidence levels on achieving that from the question. Is that a different, would that be a different response?
It would be a different response because, as I mentioned earlier, we now need to, based on the shaping organization, actually come up with an articulated plan that says this is what we can actually do. And then based on that, as a board, we get to a level of confidence that we have a route to achieving it in a time scale that's acceptable to within the resources that we.
Thank you. Tim?
Yeah, it was kind of on that. I was, when I first read it, I thought, right, we've got a plan. But reading it, again, you kind of, we've got a plan to have a plan. And I'm kind of, Rafiq's kind of confirm that a little bit. I'm thinking, particularly given Leah's opening remarks on it, we need to have a bit more structure on when this is coming back to us and timelines, who's doing what by when. It's just describing that we've got this problem and we'd like to fix it. And this is kind of how we might fix it. It's just really, and there's no recommendation of kind of when we get this back.
Great. Any thoughts?
So happy to commit it coming back. I think what I would link it to is your colleagues remember all the discussion we had around clinical leadership model, and the fact that what we've done so far in the switch that's coming in April is we have sorted all our arrangements for level 2 and level 3. This is really saying actually at level 4 there's stuff happening and it isn't delivered in the way that meets these standards. And the next phase with our new leadership that is coming in is to say, for each individual member, this will apply across 50 old specialties. Not all will have acute stuff, so let's say maybe half or something. But this is a big piece of work. So what I want to emphasize is this is pretty big. And so we need to be planned carefully, but in timely fashion. So if Chair, you're happy, we will take it away and come back with some proposed timescales. And hopefully it will be suspected to work.
Okay, so is it going to come back to the next public board with a proposed time scale?
I'm happy to bring back a proposed timescale at May. Yep, happy to bring that back with the timescale then, proposing what we want. Okay.
I think in terms of just sort of being clear where we are. Sorry, Owen, did you want to come first?
I think it is pretty big piece of work, but I think it's replace some of the things that you've already said. This is not new. What we're implementing here is something that in other trusts of our scale has been implemented. So the question for us is, how can we get to an adoption place quickly? So yeah, recognising it's complex, but there's a lot of paths that have been trailed on this. So the acceleration of this, and I think the opportunity that the clinically led governance gives us now is that we've got subject matter experts who should be able to really drive some of this through. And there's lots of examples nationally about how that's going to be done, and there's lots of examples nationally about how it's done affordably as well. I think when that report comes back, Chair, when the date's agreed to come out the next full report, I think you want to really see how do we go at this at a pace. I think I know you're saying, but telling ourselves, sorry, that we're complex and we're different, I just don't think it applies in this instance. I think we just need to crack on with something.
Okay, thank you for that. So I think in terms of where we are, so our first recommendation is receiving the assurance assessment and the findings. So I think we can receive the assurance assessment, can't we? Because we know that we're either compliant or not compliant, so we understand that. So that feels like something we can accept. I think what I'm hearing and would agree that the 7-day service is an improvement programme we haven't yet seen. So that's what's going to come back to the board in May. But I would hope that it's not going to be the first time that board members will see that. So perhaps it's something that can come through policy beforehand with the pace that Owen's suggesting, and then it should link to bigger standards as well. I think the two again are intrinsically linked, aren't they, in terms of how we go about delivering this. Because I don't think there's anybody around the table suggesting that this isn't an important priority for us. Sounds like it is, but how we get there is yet to be articulated. And I guess we could come back to either quality or the improvement board before it comes back to board in May.
And could I just come back on that, Chair? What I was proposing is that in May, I should be able to articulate a timeline that describes when we'll have the fully articulated plan and a rough timescale for implementation based on discussion with the teams. I don't think that, well, given the organizational change and the complexity of the work, and by complexity, I don't mean that this is any more complex than other organizations. The fact that we don't have the foundations of having done similar work here, I don't think it's realistic to expect a plan in May. But I think we can commit to a timeline in May, which I'm happy to challenge some, especially if we're going to go through one committees first, because that obviously.
Suzanne, sure.
My comment perhaps it doesn't stand if that's what in terms of supporting what Reeks just outlined, because if we're working through a route of it going to board, next public board in May, and to think it's journey through quality committee, I think it's important it goes to the finance and performance committee too, because we need to know the extent to which it's going to contribute to our constitutional standards. And we're doing that work as well at the moment, aren't we, about what's our plan and what that look like in the first sort of period and the extent which is to contribute to it. So we don't want to miss that bit out to 2023.
Okay, well, let's take an action to map the route then.
Yep.
Rather than saying let's come back in May, because if we're only coming back in May with a plan to develop a plan, then that would feel like it doesn't deal with the pace issue, and there might be things that others need to consider that will help in the development of what that plan timescale looks like in between. So we agree to that. Okay, great. Everybody okay with that? Thank you, colleagues. Okay, so I'm going to move us on then to the violence prevention and reduction standards. Oh, sorry. Yeah, you want to add anything? Oh,
No,
it's my paper. Yeah, okay, up to you.
It's time that it comes here, isn't it, when we've had the when one of the staff story, which we've had. So I think it provides some really helpful context as to why this is important and why as a board we need to be aware of where we are against this. There's been and this is an update on compliance with the NHS violence prevention and reduction standards, which have been revised. There are a number of questions that are asked in the revised framework, 43 standards, and they're set up into these domains. And we've done a gap analysis against these domains, and you can see where we are with those, which show we've got an opportunity to do some significant improvement around here. I think we've been fairly honest with our assessment here, which is why it's showing so much amber and some red. We've set up a new group, which Gareth is a key part of that group, to try and to oversee our improvements in this area. I've referenced some of the good work that's already going on in the organisation. I think we hear Safe Haven mentioned a number of times. We've also looked at some of the investments that was made through different groups around the use of body worn cameras. So there is quite a lot going on, but I think we acknowledge that there is significantly more that we could do. So just bringing an update here on where we are, with some revised operational oversight of these standards, and we'll bring an update. It doesn't take when we're going to bring an update, but we can bring an update at a time which the board might want me to bring an update against, depending on how important this work is for our oversight. And there's quite a lot of detail in there in terms of the standards, but I have to just take any questions on that.
Okay, thank you. Any questions or comments? Yes.
Thank you. I think it's really positive to see the report. I know Gareth has been trying to move this work on, and it's great that Julia has stepped forward and taken the championship of this. We will see this connect with so many other parts of what we look at organisationally in terms of keeping our colleagues and our patients safe. It connects absolutely with the staff survey, and I said it's still under embargo, but we will consider it formally at the main board. And it connects with how we look after and support our colleagues, to seek to reduce violence and aggression. And the work plan is really detailed, and it's really positive to see it. So, as Juliet said, we did have a real story this morning from Gareth, which really helped to talk us through with Luke's experience. And I think it's a good start, but a good start is only the work, and it'd be great to see it as it comes back.
Okay, thank you very much. Okay, Rafiq.
Sorry.
Anything else? Any other comments or questions? Did you have an idea on the timescale for it to come back? 'Cause, I mean, how often does the group meet?
We've been meeting monthly. I was thinking about a 6-month update. I think it's important to us, but we can bring it through in any other way to any additional risk. 6 months later.
Sorry, Chair, I did mean to also say, would it be appropriate for it to come through the People Committee, and then we could assure up, because then we can add it to that. Apologies.
Yeah, do that. Okay, thank you for that. Any other comments? No, thank you, colleagues. Okay, so we are at 1:05. Time for a break now, so we can take half an hour and be back at 20:22. Maybe start again if that's okay. So we are carrying on with our second part of the agenda. Delighted to have Jess join us, who's our head of policy, equity and inclusion. And Jess and I have met previously. We've been on a few sessions, conversations with staff networks, or as part of the healthcare. Health equity and health program.
Health and Care Partnership.
That's right. Yeah, which is an annual program that we joined this year. It's a series of events that have taken place and continue to take place over the year. Thank you. So we've got a number of items that are under the agenda of people and education. And if it's okay with you, Aziz, I will ask you to sort of bring the things through the report of people and education, see if anybody's got any questions, and then we'll go straight into the series of reports that you've already considered at people and education and discussed as a board. So Aziz, over to you.
Thank you. Thank you, Chair. So Gertie has already gone through our identity sickness that we did in January, so I won't repeat that, but except to say that a heck of a lot of work is going on. You know, it's not just we hear about the welcome back conversation and focus on that, which is really important that everybody who comes back is spoken to and looked after and for well-being, etc. But there's a lot of other work that is going on that is producing results that we're trying to share across the organisation, and it was really great to take an opportunity to really look at different parts of the organisation, what they were doing about sickness, and we certainly felt assured that a lot of work's being done. And then in the February meeting, I mentioned earlier the DMP report, medical job reporting was at 96%, which there should be congratulations on the rest of the organisation. But we disputed those things. You know, that was something we felt that needed looking at. The one thing I wanted to just bring up that we're doing all the EI reports. There was the sexual, so the committee received an update on the trust progress against the national requirement to prevent sexual misconduct, along with a summary of the trust self-assessment against the Charter Assurance Framework. And it was noted that whilst the trust had made significant progress towards compliance with national expectations, there were 3 areas which needed more work, including training for colleagues, undertaking cases, triangulation of data, and reporting and escalation of complex cases. I just thought that was worth mentioning. Thank you.
Thank you, Ziz. Questions or comments on the notes from the 21st of January and the 18th of February? Anything that anybody wants to raise? No? Okay. Thank you, colleagues. Thanks, Ziz. That's a great note. So we're going to move on then to the series of reports that we have. So we've got the Equality Annual Report, the Equality Delivery System, and then the gap reports on gender and disability. And yes, we can introduce that.
Thank you, Chair, and I want to welcome Jess to our public report this afternoon. We do have quite a number of reports here before us, and I think before Jess starts off, I think it's really important. I wanted to commend Jess for how well these reports are written. I've spent many years struggling to understand the detail and the complexity of some of the data analysis that goes into our equality, equity and inclusion reports, but Jess's real skill is to be able to turn that into something that is so easily readable, understandable and digestible. So a huge thank you to Jess. I think it's of particular note that whilst we are required to have an annual report, required to report on the equality delivery system and our gender pay gap, Jess has also, based on some desires she had herself and questions from us last year, now developed a ethnicity pay gap and a disability pay gap. So these are not mandated reports, but again, really important that we are moving forward with being able to report on them, because we anticipate in coming years they will become mandated. All of these reports have been scrutinised and discussed in detail in the People and Education Committee in February. They are all supported by a number of detailed, robust action plans for the workforce race equality, the workforce disability equality, the National Staff Survey, our EDS, and so on. So we do have some really robust action plans that work to improve behind these. What we cannot get away from is that all of these reports show us that colleagues of Black, Asian, ethnic minority, colleagues with disabilities, colleagues with protected career choices have a less favourable experience than their counterparts. It is important that we acknowledge that, and then it is important that we work to improve the experience of our colleagues so that we are levelling it up to the experience that everybody else experiences. So I wouldn't want to take any more of Jess's time, but I do think it's particularly a massive thank you to Jess and to her team. These are incredibly well written reports, and they are really great to see here today. Thank you.
Okay, thank you. So I really wanted to start first having a look at the annual equality report. And as Gertie has outlined, really, that gives a sense of where we are in terms of the organisation, in terms of our aims. Obviously, having had a chance to go through them as well, it looks at our objectives as an organisation in terms of those equality objectives. And then looking at that, how we address that against the public sector equality duty. We've tried to frame it in that way in terms of looking at how we eliminate discrimination and harassment and victimisation and the work that's going on for that. We look at advanced equality of opportunity as well and look at the pieces of work that make up that and the work that is going on across the organisation to address that and to support that. And finally, as part of that public sector equality duty, we also look at fostering good relations between people with protected characteristics. So all of the report in terms of that leads to that. We've set it out in a way which we can follow the path, follow the work that's been taking place across the organisation, and I hope it finds clarity in terms of doing that. What we did want to do, and I think Gator mentioned really, is to really say, well, what are the key areas of work that we're taking forward? How are we addressing that? You know, things like the sexual safety policy, things like allyship training, the things that we've started to put in place and have moving forward to do that. I think it's important that we recognise, and we've mentioned that in the report, that this is an ongoing process. You're starting to do that. What we want to do in terms of looking at that and almost so what, we've got these things in place, what happens next. So as we move forward into 26, 27, some of that work will be looking at the impact of the things that we've started to put in place across the organisation, the impact of those policies, obviously policies around the people, but how we move those pieces of work forward. So we can look at it and say, well, what are the things that are improving? So we can celebrate the improvements. I think it's important to be able to do that, but also to look at the real challenges or the areas that we know that we need to improve. I'm going to leave it there for the annual report unless there's any questions.
Okay, thanks for that, Jess. Any questions or comments on the annual report? Oh, wait.
I guess we still we're stuck, aren't we, on things like band-aid C roles, particularly if you're black or if you have a disability. And I am sort of emphasising the word black because it seems to be, and we're going to come on and talk again about some of the pay gap reports and stuff like that. It's quite striking around some of that. So we are doing work around that, but it still feels like we've got a bit of a shortfall. Is there any thoughts that you've got about what we could be doing, not what you are doing, what we could be doing more, maybe to help, particularly on some of the, if you do the intersectionality of some of this, it gets even starker, doesn't it, around that. So there's just a question really about if you were in a canteen in the public forum now, but if you were in the room and you're saying, God, I wish them lot could, what might be the answer to some of that?
I think in terms of looking at that 8C, we've started looking at the progression. Let's have a look at that. Let's have a look at how people are progressing within the organisation and to really look at those opportunities for 8C roles, looking at where that is, really looking at the starting in terms of recruitment. So for me, it's about looking at the starting point. If we know we're having issues in recruitment, how does that follow through the organisation? Because I think it does. So for me, it's really looking at, well, what are the things that we can put in place that really bring change? How do we then move forward in terms of the things where people have mentioned it but don't feel the change is quick enough? And I think that's one of those areas. So if we're sort of saying bullying and harassment is one area that we need to focus on, but that might take us 12 months or so to address some of those things. I think that would really make a difference when we look at things like the reciprocal mentoring and again engaging senior leaders in those programs of work. Again, those are things where we are showing that we can make a difference and how people are engaged in that process and the senior leaders engaged in that process.
Just a third one, it's not probably more a question for Rafiq or colleagues who've been involved with CLM. So if we looked at the demography or characteristics of our CLM now having done levels 1 and 2, how different would that be to the the departure lounge and where we've currently been and where we're going to, what does that tell us? The things got better if you're a black person, somebody Asian, if you're a woman, things got better.
We don't know yet, because not all the appointments have been made, and it will be reported probably end of next week or the week after. Judging us having that information.
I think it'd be, even if it's a side note to the board, I think it'd be useful for the board to have an understanding about what that looks like. And whether we do it, because I think we all know that when the restructures typically, people with protected characteristics tend to end up being in the wrong place around that. So I think it's just important for us to just understand what's it looking like for us on that. Probably got more to say, reserved for them.
Okay, thank you. Jeff?
First of all, I agree with Gertie that this incredibly readable report, well done, very helpful. Two questions. On section 4.3 on health and qualities, first of all, is there any more information on what we are doing to support local residents of the communities we serve to apply for and get jobs within the NCA and then to progress within those jobs, so that we are using our as an employer to help reduce both deprivation and where that deprivation rates to people with protected characteristics help that as well. That's the first question. Second question relates, as opposed to the bullet point under the actions completed in 2025 about fit testing and looking at that through the lens of ethnicity. And it proposed in my mind question whether on a more general basis we are targeting diagnostic testing with those neighbourhoods with significant levels of deprivation and or neighbourhoods with concentrations of people with protected characteristics, where those particular diseases or conditions are most prevalent. And then on the back of that, targeted testing, therefore focusing our interventions, our treatments on those people and places where we've got the widest gaps. I hope that makes sense, but it's whether that follow through happens in terms of targeted testing and then intervention on the basis of protected characteristics and or deprivation.
Okay. Are you able to, do you want to respond to those, Jess or Gertie, or do you want to come back to them when we've got a few more?
I can come back to the first one, the first point that you made. Our widening participation team, so in terms of the work that they do, is looking at our demographic profile in terms of our local population, and then doing targeted piece of work to support local employment as well. I can get back to you with more details around those programs of work. The second one I would have to come back to unless anyone else can respond.
It's not on the second one. It's actually fortuitous. I went to the Joint Health Overview Scrutiny Committee last week just to talk about widening participation and the work the team had done. I am on.
Just couldn't hear you.
Oh, sorry. That's not something I could hold on. So there's been quite a lot of work done in terms of supporting employment from our local communities, particularly around increasing our representation. And we've looked at different methods of recruitment into NHS roles, looking particularly to remove barriers. And we've seen an increase that's at November 2025 against a target of an increase of 60%. We've seen an increase of 59.74%. So there's quite a lot of work. We have done a lot in terms of T levels, apprenticeships, cadetships, bringing colleagues in and supporting them. Colleagues will know, and we'll have seen it in lots of different fora, but one of the key actions around making our recruitment much more inclusive is around sharing questions in advance to support those colleagues who are either not first language English or neurodiverse, etc. So there's quite a lot of support One of the key other elements in terms of widening participation is educating ourselves. There's a recruitment and selection training programme that the recruitment team have developed, particularly with an inclusive lens, so that our managers understand things like conscious, unconscious bias and how that might manifest itself in recruitment. I'm very happy to share the few slides with you, Jo, because I think.
Okay, thank you. Julia?
Kind of picking up on Owen's point around CLM, and certainly in nursing, in all of the level 2 and level 3, there are no colleagues from a Black ethnic background and only 2 from an Asian background. So I don't think that we're not selecting in that way, but certainly the pool that we've got to pull from is what is white. Jess and I have had a conversation about the barriers that our nursing colleagues in the bands 5 have in terms of accessing CPD, colleagues from who are overseas educated in accessing promotion. So there's quite a lot of work that me and my team need to do in here in order to even get to the place where we've got a selection of people who we could be thinking about into those senior posts. So I know we've been doing some particular work on it with internationally educated colleagues around there. So we've kind of made a commitment to do that work. Just need to get on with it. So I hope when we come to this point next year, we should be able to contribute something in this annual report which shows something slightly different for those, well, significantly different for those colleagues that are in nursing posts, specifically nursing posts.
Okay, thanks, Julia. Rachel?
Thank you. I think as a board, we welcome the fact that we've gone beyond what's just the minimum requirements around reporting. Excuse me, and I hope that sends a message out to the organisation that we care about it. It's something that we're interested in. Obviously, having those metrics in place means that we can now measure ourselves and measure improvement or not. So this is where the torch can now be shone on this in a measurable way. We're not alone, though, in the barriers that people face in our organisation. And I guess my question is, how are we working with other organisations to understand how we are sitting? Is it a sort of national we're about on, or actually are there organisations that we can learn from? And as much as we're not asking people to fix their own problem that they're suffering from, actually, how could we ask for some support and suggestions from people within the organisation, from different networks and groups? Again, not that we're expecting the people to solve their own bias that's against them, but obviously they can be hugely helpful set of people. Thanks, Jess.
Okay.
Yes, so one of the ways is through our staff networks. So we have 4 staff networks that contribute their information that people will go to each of those networks. And then the network chairs, I'll meet with them on a regular basis, and we'll do that to look at what some of the issues are, the things that they're bringing. Obviously, we'd like to have bigger networks, but again, it's really valuable information from the networks to have that two-way process as well. And also the reports are shared with the network, so the reports that well produced, we'll talk through that, they'll share them, and I'll go and present some of that information to the network. So it enables us really to have a look at that and to say, well, what is the data? Other colleagues will go and present some of the key issues that people have highlighted, and so they're concerned about. I think that's a real, it actually has to happen to be able to do that. I think for me, when you said about having the reporting, there is a way, if we don't see it, if we don't see the data, it can also do, it's almost like it disappears. Yeah, so I'm really keen, and the team as well are really keen that when we present information, it's something which is easily accessible, and you can just say, are we doing better or worse or the same? Going back to the first point when you asked about how we learn from other organisations, I think that's key. We look at our across our GM footprint, so we'll look at our data in comparison to other trusts across GM. For the most, we're doing similar. I think some of the issues that we're facing, particularly around discrimination, particularly around racism, are the same across Greater Manchester. Sadly, and that takes a, we're a microcosm of the greater society, so we would expect that. Where we do look in terms of our learning is then looking at well, what other trusts are doing. Some are doing better in terms of what we do. So we benchmark our res and des data against nationally, and again, that's presented through PEG to be able to say, well, are we doing okay in terms of some of the things that we're improving on, and we can look at that. And then I think through the diversity in health and social care and care partners programme, again, that the chair mentioned previously, we're looking at then, well, how do we then take that learning, look at the things that we're doing and things that we feel we're doing well, and then look at what other organisations are doing as well, so we can learn as a group of trust going through that process, the different ways that we can look at improvements and some of those challenges as well.
Thanks, Jess. Would it be through People and Education Committee then that we'll see a sort of progress and updates on this moving forward? Because again, it's making sure that we're not, you know, there's the report, you know, and actually we are showing an active interest in measuring improvements.
Aziz, do you want to respond to that?
Yeah. Still on, okay. I'm live enough. We do track that through People and Education Committee, and you know, there are things we've seen improvements on. You know, I think at one point we were 2 to 1 when it came to disciplinaries, but compared to my people. I'm part of the North West BAME Assembly, and at all those meetings they discussed this, and 50% of NHS trusts are on parity. So, you know, we did go, Nikki was chair of people then, and, you know, and I brought that back to Nikki, and we went and looked at some of the work that other people did, and we have reduced that, haven't we, Gertie? I can't remember what it is now, Jess, but we did a lot of work on that, and we did reduce that, but there are other areas that have been stickier and more difficult. So, yes, it is tracked through People Committee. We are trying to learn from outside organisations all the time. But we also live in an unequal society, and some of what happens in our organisation reflects that we are made up of a wider society and are affected by the socioeconomic realities of wider society. But that's not to mean we don't take action. I mean, we are taking action. Certainly, you know, and I've always advocated for action to support the work that Jess and all of us should be doing on this.
Yeah, and thank you, Mrs. for your contribution, because I know this has been something that you've paid particular attention through your time as a non-exec. So I appreciate that. Anything else you wanted to add, Gertie or Jess?
Yeah, just to come to add to what Aziza said in response to Rose's question. So we receive regular updates from Jess in terms of our equality, equity and inclusion. That includes because as I said at the start, there's an action plan behind all of these. So whether it's the workforce race equality, the workforce disability, or the gender pay gap, there is action against them. But we also look at inclusion through the lens of the staff survey. When we receive reports on our employee relations cases, we also consider, as Aziza said, the parity in terms of the disproportionality of colleagues from Black ethnic minority areas going through disciplinaries and other formal processes. So whilst we do receive lots of updates from Jess at People Education, I would like to reassure the board that there are a number of other reports that equally consider an inclusion and an inclusive lens.
Thank you for that. Okay, Leah?
Thank you, Chair. It was about the appointments, the clinical leadership model. So of our directors of operations, 6 of the 7 are female, so it's a heavily female dominant appointments. And we had cultural ambassadors in all of our level 2 interviews, and we had some really, you know, they were an absolute equal on that interview panel. And also we've heard from candidates, particularly from ethnic minority backgrounds, around the importance of the cultural ambassador on the interview panel and how that helps them and help them feel supported. One of the questions that was in the clinical leadership model that was passed through, I think across all of our interviews, was around inequalities, and the responses that we had were interpreted both by individually the patient perspective of work that they had done or were undertaking, or from a staff perspective of how they had supported. So lots of examples around communications in particular around how screening programmes were targeting patients that are obviously hard to reach, but they're not hard to reach. We've just not worked out a way to reach them. And so there were, it was there was a lot of positives in terms of what we heard, and I think it had been a significant question that we paid attention to both at the level 2 and then at the managing director roles. Ignore them by intent and employment.
Thank you. Jeff, you saw your light on, is that? I'm conscious we didn't answer your second question, which was about the health inequalities and disease prevalence particularly, and what's our approach around population health. I think it probably speaks to the point we made earlier about, is it something we need to pick up unless anybody wants to respond to that question. I'm guessing that's something that we might want to be at some point as a session with the board anyway, to understand what that challenge is. And Suzanne.
Thank you, Chair. And thanks, Jess, again, for all of this work. I've just sort of been reflecting as I've been listening to discussion, particularly always challenged about what more can we do, how can we support. And what doesn't sort of jump out to me from the reports is some of the work that we've adopted in some of my teams in finance. Our finance improvement board, we sort of purposely trying to put some focus on how we can be more progressive around supporting protected characteristics colleagues, advanced development, how we support in that space. So I guess it's an offer and an ask if we can perhaps put this outside and work together on how we better connect some of the work that you're doing into the work that we're doing to make sure A, we're on the right track, but B, that we can see that it's contributing, that's making a difference to some of the work that you're doing.
That'll be really helpful, thank you.
Brilliant, thank you. I just had a question around, I think it's great to see that we're sort of meeting the equality duty standards, but it feels like that is the minimum expectation. And I suppose I'm just wondering what our ambition is. So we've committed to the anti-racist framework and we're at bronze, I understand, in 2024. So what's our ambition around that? And is there some, what's our expectation to get beyond bronze around some of this work? And is that something that the board have articulated previously?
Yeah, I can answer that. So our ambition is to get to silver standard by the end of this year. There are 5 metrics to do that. I'll have to come back with the details of each of those metrics, but there are aims and objectives in place for us to move forward. Things like the levelling up leadership is one, levelling up management is one of those areas. Looking at our data and looking at how responsive our data is in terms of being able to look at ethnicities, being able to look at progression is one of those areas. What we are doing, and we have an anti-racism working group to start looking at that. We established that last year to be able to do some of that work, and we tied that in with some of the issues that are coming up for our international colleagues as well, internationally recruited colleagues rather. So again, it's sort of bringing that work together so we can look at, are we on track to progress in terms of that action plan? I think I presented the details of some of that to PEC toward the end of last year in terms of that, the actions to take that forward. It is an ambition, and I think it will be challenging for us to meet that by the end of what is now this year, but it's still something that we are aiming to do.
Is that the end of the calendar year?
End of the calendar year, yeah.
And just following on from that, Jess, I know that the kind of attendance at and support for the networks are variable. So is there anything more we can do to support around that, from a board perspective, around sort of, kind of championing the networks or encouraging a wider engagement, or is it, are they resourced appropriately? I don't know.
Yeah, I think from some of the conversations with the network chairs, both in terms of their time to attend the network or to be able to support the network is a challenge. I think it's fair to say. I think there's different people can attend the network meetings, so they will hold meetings, and they've tried to do that online. They'll have WhatsApp groups. They're trying to do different ways of engaging staff in some of those conversations. So they, and I think the last one, they had a walk around sites to do that. I think really from a senior leadership level, it is how do we promote that? How do we promote the importance of networks? How do we say that is something that is valued, and the information that they provide, and the support that they provide? How is that shared at a senior level, and it can be emphasised that yes, it's something that is key, that is something that is valued. I think at the moment, for them, they're feeling that they're doing this in isolation. It's fair to say, and it would be great to have further support for them to be able to do their work.
And one of the things that we had fed back on the interviews for the managing director was a real positive affirmation and a kind of call to action to us all to attend the allyship training, which Dave said was the best training they've ever been on, which is pretty fantastic. So I think they've done a lot of training in their career. So that's something that we can all take away as an action as well, I guess, really. Okay, conscious of time, but sorry. Sorry, go ahead.
Just in the vein of pledges, there's an aspect about what we do more to promote the network. So can we all take a pledge to do that as board members, and to be able to, if guest asks us at a point in time and says, well, how have you done that, for us all to be able to provide our own little evidence about how we've done it. I don't think that whether you're executive, non-executive director, I think that's a pledge that we can take on. I think there's just one thing I would also say when I was talking earlier about CLM, I would also apply this to corporate changes as well. To what degree can we change? We'll be doing a target operating model and whatever else. The before and the after, what does that look like across characteristics? I think it's something that we also need to understand. It's not just a CLM specific question. And then I think there's just a thing where I want us to all be challenging our thought processes about the degree to which we might view people as being ready now to step into roles, and this thing about pipeline development. Because in some of the work I've been doing, certainly with our overseas colleagues over the past 3 months, there's several of those colleagues where, for example, in qualification terms, they're more qualified than me. There are several of those colleagues, particularly when in other parts of the world, for example, they have held jobs that are quite senior, but due to the nature of coming to this country, by being invited to come to this country and provide support and healthcare, they find themselves in roles and doing things that are, as you use language, of a lower level to what we've been used to. So there's a question for me, and it came out in the sessions that I've been doing about the equivalency we put on qualifications and experience. And do we have a different standard for these colleagues? When the relevant experience will be acknowledged, but are we acknowledging relevant experience if, for example, it comes from a different country? So I just think there are some things that we need to think about, that we need to pay attention to, and just ask ourselves, are we potentially introducing some biases into the way we do things, that we really stood back on it and say, well, if somebody has got a PhD from Nigeria, are we really saying that that's not equivalent to what we might see here with the outlook? And then I think there is a final point. It's great to hear about the allyship work, but we have a cohort of management that when we talk about this work and becoming knowledgeable in it, that it's not necessarily naturally appealing to them, or perhaps if they are invited to or a part of development programs, they come there because they feel they have to, rather than they are interested in the subject matter. I think that's something that we just need to reflect on, and then think about how do we change that mindset to kind of it's not really an option. We're kind of in it or we're not in it. So I'll just give that reflection, and I'm not just saying this is anecdotes. There's some evidential points that I can talk to substantiate that point. I'm happy to have that conversation outside the meeting, but I do feel that we've reached a point where we need to be, to the chair's point about the ambition. What does gold look like? And if there's a platinum, what does platinum look like? And what would we need to do to shift that dial immediately? So just some reflections, some thoughts, and just asking us to make sure that despite what some of the people outside of here would say about this agenda, if we're committed to it, well, let's show it.
Thank you, Victoria. Rachel, how did you?
I think we make it mandatory. If we want people to do it and we think they should do it and that everybody has to do it, we make it mandatory. In other organisations I've worked in, it has been mandatory. Now there are lots of schools of thought on this, aren't there? That if it's mandatory, it's not playing to hearts and minds. But health and safety doesn't always play to hearts and minds either. We've just got to do it. And the other thing is, how are we compelling people to actively do something about the inequality in their team? We put a measure that we measure them on. Again, the organisations where I work will, as part of your objectives, your percentages in your team are reviewed against a target. And if you're not meeting them, you are not meeting your objectives. And it's within our gift, maybe not today, but as part of a plan to look at how we do something about things, is to actually decide when we're going to do that as an organisation. It might not be something that stays permanently because it's a current cultural issue. But that is what we have to do. I may be being a bit simple here, but we will never win hearts and minds of everybody in this area. I hate to say that, but actually it's not about, it's about the organisation doing the right thing for both the population and the people. And we know that having a workforce that isn't representative of our population leads to worse outcomes for that population, as well as a bad experience for our employees. So, I'm not saying that is something we need to decide on today, but asking ourselves why we haven't got that. Do other NHS organisations have those in place? But I've heard lots of great things about having people in interviews that are challenging those bias. That's brilliant, but again, it's about then having mentorships of certain groups. It's about having development training courses for those groups specifically. It's supporting those groups in knowing that they can go and ask for informal coaching, because they would be less likely to ask internally for an informal coach than a white colleague. We know that from what research tells us. So there's a lot we can do. I just think it's, a good step is each and every one of us finding a group that we want to support and champion, and making that a formalised thing as well, so that the organisation understands how much we care about it.
Just wanted to talk about the mandatory point. I think the point I'm trying to make is not that, for example, people don't attend something, but there is feedback, particularly from facilitators who facilitate it, that when people are in situ, there is a narrative by some, and I've got to be really clear, I don't want anybody to think it's all, but there's a narrative that comes back, which is a kind of a combination, but I only came because I had to.
Yeah, I think your point was really well made. I think, unfortunately, that is in a lot of organisations.
Or it's, I don't really believe in this sort of thing. And maybe part of that intervention is about, so what do you do if you are a facilitator and you are facilitating that conversation? Or in the language of allyship, if there's somebody else in that development session and hearing that, what's the conversation that happens in the moment? Because if those conversations are not having the moment, they just get lost. So it's not just about the attendance and stuff like that. It's about what happens in the moments when people, the teachable moments, as the US people might have talked about, what happens in those moments. Conscious of time. Yeah, sorry.
Thank you. Thank you. That's all helpful points. Thanks, Rachel. That's all right. Okay, so I've got a few recommendations here. One is obviously to be advised that the date meets the public sector quality duty. The second is to be assured that the annual excellent equality report ensures that we're compliant, and then we publish the report. So it's an agreement to that. And then support the changes in terms of the calendar year to the financial year. So that's notwithstanding all of the good conversations I think we've had today around what else we could be doing. And of course, we're always reporting on our objectives soon in terms of appraisals. And so we'll pick up some of those suggestions around demonstration of some of that in those conversations. I'm really comfortable with that. Yeah. So we've got the equality delivery system. Jess, anything you want to add in relation to this?
No, I think most of the points I think have been actually, what there is one point. I think it's important to highlight that we are now achieving in terms of what we have in terms of the equality delivery system. Before we were seen as developing, which meant we were doing the minimum. Now we have moved up, and that is around our commission services and patient services, and also in terms of the work that's gone on through our colleague experience team and looking at wellbeing. And I think it's important to recognise that because it has taken a lot of work for them to actually move up, even though it seems only 1 or 2 points. That there is quite a rigorous sort of measurement of where in terms of benchmarking, and that has been achieved. So I think it's good to see that we are making some improvements and now looking at achieving, which is really important.
Sure. Yeah. No, that's really important. Thank you for sharing that with us. Any comments or questions on the equality delivery system? Is there anything that we need to consider in relation to what happens next with the EDS? Because obviously it's not being monitored by NHS England now, nor the ICB, I think I read as well. So what's our thought process on that?
I mean, it's still detailed in the standard contract as something that we have to do. So it's looking at how we can do that differently. We don't need the ICB or in some ways the input that we had before. But I think it's still important that we do it. I think it's still important in terms of those metrics, looking at how we improve equity in terms of our commission services and those services really taking that on board as well, and they have done. So for ourselves, I think it is something that we progress with, knowing it's not reported, but I think it is something which is still useful internally for a measure of how we are doing it to make sure we're still maintaining that achieving and not slipping back in any way.
Sorry, thank you for that, Jess. Any other comments or questions on EDS? No, so that's to know the positive direction of travel in terms of achieving from developing, the fact that NHS England are not collecting returns, and this will remain with us. And then last thing is around that it's been completed with the guidance. So that's for us to know. Thank you. So let's move on then to the pay gap reports then, Jess.
Okay. So again, as I said before, so we have the gender pay gap, which is obviously a statutory requirement, and the details in that one. I think again, sort of to highlight really that we are when it's comparison is around everyone. So in terms of the organisation, when we look at the gender pay gap, it's looking for all roles. We're not looking at comparing the same role and comparing the experience of men and women against that. It's looking at every woman in the organisation, every person who identifies as a woman, every person who identifies as a male. So we're looking at how those issues are, looking at how the average is in terms of pay. And we can see from both the gender pay gap and when we talked about the ethnicity and disability, when we come on to that, we are not improving in those. We have sort of the gap has widened, even if it's only slightly. So we are still away from where we would want to be. I think it's important in terms of when we look at the pay gaps that we understand the ongoing impact. We have looked at it in terms of that cumulative gap. So what happens in terms of we present the data and we collect it in the way that is required, because it's looking at it's per hour, and that looks at the working of per hour. We then wanted to look at it per week. What's the difference, and also look at that cumulative over over a year, over 5 years. We have presented that differently, but I think it's important really to do that, to show those gaps and to show why, even though it sometimes is only a few pence, when we look at the future impact of pay gaps, it can be significant for some people. That's all I want to say about that one at the moment, and I'll move on to the others unless there's questions at this point.
Okay, can we take questions? Tim?
Just one on, I mean, the second recommendation is around considering the potential cumulative impact of the pay gap in relation to our decision making. I was kind of intrigued by that. How will we do that? I was thinking, are there any examples where we've been presented with something at board where we can make better decisions to influence this? Kind of struggled, so we need to engineer so we do that.
I think it was, from ourselves, it was more of an ask for that to be considered. So if some of the papers that come to board, how do we then look at some of those decisions around, I don't know, around pay or performance or any of those things in relation to pay gaps? I'm not sure whether that's considered. So it was an ask really in terms of bringing these papers and asking for that to be a consideration, if that is something which is brought to the attention. So we look at, well, how is this going to impact in terms of our gender pay gap? If we're making decisions, how is it going to look in terms of our ethnicity pay gap? So really it's thinking about the reports as something which is not just presenting the data, what does it mean in real terms, and the impacts of some of our other decision making.
Yeah, it's an interesting, it's quite a tough one to, it's up for us to kind of work out.
So, thank you for that, Tim. And I guess, I mean, it's disappointing, isn't it, to see that the gaps widened in terms of gender particularly. And I suppose the explanations given in the report is around the clinical bonus systems, clinical bonus payments, sorry. I'm sure that's the clinical, what did they usually call clinical bonus? Yeah, are they still a thing? Is it a historical?
I think things can born as something different. But the principle and the impact it can have.
So
that's it.
Okay, so what's been our approach around that? Did you want to respond to that?
I was slightly more answering the bit about they still a thing. So they were discontinued under the revision of the consultant contract, I think, 2 years ago from memory, or I might be slightly out a year. So it was recognised nationally that Clinical Excellence Awards, there was a significant disparity where they clearly looking at national data were rewarding white males versus ethnic minorities and all women, and there was inherent discrimination and disparities in the process for the application, which was one of the reasons why they were reviewed and taken out. Obviously, as part of a wider pay review and part of the pay dispute between the BMA and the government. Then they are now normalised into pay and go through seniority. I would say in terms of what were we doing, because if you had one, you retain it. So we can't perhaps influence it. I would imagine the NCA, like every other organisation, sought to encourage female applicants and applicants from minority ethnic groups, provided examples of how to fill in a form well, etc. But it's not a process we have live anymore, but they will continue as a legacy for as long as those consultants who hold them are here. And that could be 20 plus years, if you think about the lifespan of a consultant.
Rachel?
My point was answered. Yeah, thanks.
Okay, do you want to cover off ethnicity and disability as well? Yes.
Yeah, sure. So again, in presenting both the ethnicity and the pay and the disability pay gap report, the same issues are there really in terms of looking at this disparity. There is a gap. Obviously, in terms of looking at ethnicity pay is more nuanced because we break that down by all characteristics in terms of ethnicity. But what we can see from the ethnicity pay gap is that disparity for colleagues from Black British, Black African, Black Caribbean heritage, that is there in terms of the metrics, in terms of lower pay across the whole of the organisation when we do comparisons. When we look at disabled and non-disabled colleagues, again, with a caveat here with this one is that we have more people who do not share whether they are disabled or not in terms of their ESR data. So that is a caveat to the data. But again, it still shows a gap across the whole of the organisation when we compare disabled and non-disabled colleagues in the favour of those who class themselves as being non-disabled. There's some slight nuances in that we look at for bonus pay, but when we look at broadly, we can say there are disparities in our pay reporting or in our pay gap, which we'd want to see closed or less of a gap.
Okay, right. Thank you for that. Any comments or questions? No? So there's 3 recommendations here. One is obviously to publish the gender pay gap by the 30th of March and also support publication of the ethnicity and disability pay gap reports and to consider the impact of any pay disparities in terms of decision making, and then one things around supporting actions to improve increased data reporting in ESR. Everybody comfortable with those? Okay, thank you. Thanks, Jess. Thanks for joining us, and thanks for all your hard work in the in your role and particularly supporting the networks as well. And you do a great job there with the difficult circumstances. Sometimes trying to encourage that wide range. Okay.
Thank you.
Free to leave if you I'm sure you've got plenty of other things to be on.
I do, but thank you.
Thank you for joining us. Should we move on then to the fit and proper persons policy?
Yeah, I'm just asking the board to note that the chair has asked for additional level of scrutiny, so I propose to withdraw this policy and we'll undertake some review outside of the board and return for approval at a later board.
Yeah.
Just one consideration in that review. In this section in it that talks about if there's a concern, could we just give some consideration as to whether there might be some timelines for when the various actions, so again, suggestions about the chair would do this or whatever else, but doesn't then say to you is what might be a reasonable length of time. It's not something to go through, and it's a kind of a continual point I'm making about grievance procedures and FDSUs and stuff like that. I'm thinking this, we talked to you about outside dirty, but it just really, I want to be good to just have some commitment to times, always effective, that it's not always straightforward. Some of these can be complex. But it's in the commitment bit. What do you do to, thinking about the timelines? Thanks.
Okay, thanks. Owen can pick that up, sure. Okay, anybody got any other comments or questions on that? No. Let's move on then to Charitable Funds Committee. Rachel.
Thank you. I'm assuming the report has been read, but the only update I wanted to make really is number one, thanks to Jeff. You've been chairing the committee up until this last meeting. We've only had one since the last board meeting, and chair has passed over to myself. The only update I think what I would like to make verbally today is around the Charity Committee 2024-25 annual report and accounts. So that final draft was approved on behalf of the Foundation Trust Board as corporate trustee of the charity. So just to let you know that that has taken place from a formality point of view. I didn't have any other specific update I was going to make verbally, but I don't know if Jeff wants to know. Okay.
Okay, any questions or comments? That's supposed to receive the summary report. We have to do that. Okay, thank you, Rachel. Thanks for picking up the chair's role too. Let's move on then to audit and risk. Tim.
Okay, yeah, as you can see in the alert section are the range of overdue audit actions that we look at in terms of extensions and holding kind of the lead execs to account for progressing those. I think they've been kind of this is well rehearsed before. I mean, the Loxips one has come here through Quality Committee. And, I think the learning from some of that we talked at previous boards. So generally content that actions are on track across all of those. Other areas on the advise current audit reports, cost improvement one gained a moderate assurance, which in auditor's language is quite. But even so, we spent some time on that, given the importance of quality impact assessment in our current climate, because so we don't kind of ignore the recommendations. So we will be keeping a watch on that. Second one, just apologise. There's a typo on patient and public engagement. That's my fault. In emergency services, that should be maternity services. So it's positive report, but just to adjust that. Just looking at other areas that I'd flag, the things that Tim has already sort of signalled in terms of issues coming to us on risk management and CLM governance at the committee. And also some discussions around how we, with the Research and Innovation Committee being stood down, how some of the digital issues will be absorbed by the Audit Committee. So I'm talking to Lorna about that. So those are the main areas. So happy to take any questions.
Okay, thank you. Any questions or comments on the audit and risk? So I know you'd alert us to the fact that lots of the internal audit actions have been extended, and are you comfortable now that the appropriate, because some of these are really important and critical to the things that we've talked about throughout the meeting today, particularly around policies and medical job planning, for example, the WHO, patient initiated follow-up. Are you confident now, Tim, that progress is being made, or Suzanne, do you want to respond to that?
Yeah, I'm happy to go really up to you, sure. But I think we might have picked it up at the last update. We certainly discussed it in the meeting.
Yeah.
We've got to make sure that in terms of that oversight and tracking and making sure we're meeting the requirements of those deadlines. It's a dedicated item on our executive agenda for our colleagues to make sure we don't end up in a situation where we're going necessarily for extension. So we've made sure that's strengthened.
I know we didn't cover it last time, but because it's an alert again, it feels like it's not.
That's why I was trying to remember where I thought we didn't we?
Yeah.
I think it's the range of them that are in the alert. Yes, I mean, Suzanne says it's now stronger that what was becoming apparent at the audit committee was that things have been agreed to, were now locked into, that if the execs had a chance of being upstream, they may not have agreed quite to the ambitions and the deadlines that were there. So it's kind of fixing that issue. And this is kind of the tail of that working through.
Amazing. Okay. Any other questions on what I guess that's supposed to note? Thank you. Thanks, Tim. Okay, let's move on then to the placing. In fact, actually, let's go to the clinical strategy, because Tamara's just joined us. So welcome, Tamara. We'll let you we'll deal with the item on the agenda, and then we can pick up the other for collaborative partnership. That's all right. Okay, so this is on our clinical strategy. So
Thanks, Chair. Yes, I am, if that's all right. So, colleagues, we now have our clinical strategy in draft for board to consider, and we are seeking approval. Hopefully, this is not a new document for colleagues. It's been discussed lots of times in the strategy group and one to SMT as well. It's there. We, as a collective board, had a planned development session which didn't quite come together because that needed to be displaced by other priorities. But all NETs should have received this, and I think some of our NET colleagues have also been involved in workshop style discussions around this. So hopefully it isn't a surprise to colleagues around the table. As with any strategy, it's try to balance being clear on directions that we need to take as an organisation, without being overly specific in terms of delivery at service level. Now that we are reshaping the organisation, there will need to be follow-on work in terms of specifying at service level how that is translated into the reality. It is not meant to be a plan with the specifics there, so let's just keep that in mind in terms of the discussion. I'll hand over to Tamara in a second. I also want to just note that when we started this work, we had a bit of discussion around the site angle of things, which a couple of colleagues have sort of raised as a point to discuss. And we had noted that there wasn't going to be a site configuration strategy as part of this, that something that would be done separately. So I think that's my introduction. Tamara,
yeah, just a couple of things. I think when we've been doing this, we've also tried to strike the balance and recognise the range of services across the NCA. So the services feel they can see themselves in the strategy, but it has been a challenge because of the kind of massive range of services we provide. But we've really tried to kind of recognise that across the spectrum, from community to acute, local to regional services. In the engagement and the feedback we've had so far, so the principles, the 5 principles that are really the core of the strategy, have been really welcomed by colleagues and partners across the system. And they've also kind of really welcomed having an NCA-wide clinical strategy that reflects the current context. But as Rafiq said, I think one of the challenges has also been being really ambitious, but also recognising it's a public document. So really it's aimed at our communities and our patients. So being conscious about what we say in it, but that needs to be an agreed, pre-signed up to direction of travel.
Okay.
Thank you, Chair.
Thanks, Mark. Okay. Any questions or comments on the clinical strategy? As colleagues have said, you may have seen this before, or certainly it's circulated in advance and socialised in advance, so many of you may have had information already. Lorna.
I think, and I look back through even just the things we've talked about today and the reports that we see and the challenges that we face and all of the really challenging pieces of work that we're trying to do to improve care and services. When you then look at this pulled together, it's actually really inspiring in terms of the scale of what we provide and the breadth of what we provide. And I think it's a really helpful document. It's really helpful for our staff, for us, for our patients and communities, because I think it brings to life just the wealth of skill and capability we've got about what we're delivering and how we're delivering it. And I think there's something that we have to remind ourselves as well, that although we've got an awful lot of problems to deal with, this sort of demonstrates why we're here. It just feels important to recognize and a great piece of work, really.
Thank you. Okay. Suzanne.
Thank you, Chair. So just recognising the point that Tamara made there about not being only specific around it, as we've had lots of discussions and we're referring through the development of this document, that now we have something that does all the things that the colleagues have described. How we use it as a really important framework to connect to other things that we're doing, such as our national sustainability plan, which is not just about financial sustainability, it's financial and clinical sustainability. So we will absolutely be as we take that forward, and colleagues can expect to see when we finalise that FSP document a real read across between those two things. The first section will almost be repeated in terms of what we're about and what some of the things we face. So I think those are just two really important connections for us to make when we receive this.
Thank you. Any other comments or questions in clinical strategy? No. Okay, so a couple of recommendations then again on 3 back that we reviewed the final document, which is in front of us. We approved the final document for publication, and we know that there'll be a public vacancy summary that will be co-produced with our patient and public voice partnership. Is there a timeline for publication?
I think so. After approving here, the plan was to liaise with comms and to do some comms around publications. So I think as soon as possible.
Okay, well, thank you. Okay, everybody comfortable with those recommendations? Okay, thank
Chair,
you.
if I may just to say, obviously massive thank you to our colleagues here, but just special thank you to Maura and Alistair for the compliments today, for fronting this, for all the strategy colleagues who contributed, and a massive number of our colleagues who have been engaged and contributed to like this in the end. So just wanted to thank you.
Agreed, thank you, and it will obviously inform our refresh of our overall overarching organisational strategy as well. So yeah, do thank you. As well about that. Thank you. Okay, sorry, you keep welcome to leave. Let's go back on the agenda then to placing for locality partnership paper. So go to.
Yeah, thank you, Chair. I'll just put a few key points. I think particularly around the context and timing that we find ourselves in terms of the time the report was written. That we know from April 26th, the GMICB are introducing a new operating model, and it brings substantial change at our place level. Pull out also that there's a GM standardised partnership agreement for all 10 places. It does align closely with the agreements already in place, which is positive. With a new locality grant, which is being introduced, the intention is it'll run as a shadow in the coming financial year with full implementation April 2027. But this is particularly important for us because it's ring fencing resources such as the Better Care Fund, minimum investment, population health fund, and that fund filing for left shift. That obviously left shift is a particular area of importance for us. We don't have detail of that funding at the moment, and we will continue to see that evolve over the coming year. There's a newly configured place teams. They'll be in place from April. Again, the voluntary redundancy and the changes within the ICB does create some pressure around that and the start of the transformation. I think the only other thing I'd pull out would be the CEO in place leads, reinforcing the need and the importance of maintaining strong partnership arrangements throughout the upcoming period of change. At the time Andrew drafted this report for us, neighbourhood plans weren't available. They have since been shared with us. So just a brief update for the board. I wasn't going to pull anything else out, Chair, but happy to take questions.
Okay, thanks, Gertie, for that. Okay, Aziz.
It looks tricky, doesn't it, this, because nobody wants to be left holding the ball and everyone's ducking it. And actually, it's really important, this. I mean, we don't work with the places properly. I mean, you know, they're saying the movement of funding, this is part of the 10-year plan that, you know, the move service. And you read this report and it's like, well, we can't fund it. Well, you can't fund it. I can't fund it. It's a bit scary reading this when this is what the NHS purports that it wants to do. And yet ICBs aren't funded, don't have the funding for it. They're being cut. And it just, you know, I'm leaving soon, but I read this and I think this is part of the 10-year plan, and that's, you can't have a plan without places if you want to transfer services from hospitals to where people are. And I just, I don't know, what are you going to do? I mean, that's the question.
You make an important point, Aziz, and certainly it's going to be one of my questions about what's the risk to us of some of the proposed changes. But I'll ask Jeff for his contribution, and then we might have some further thoughts on that. Jeff.
That's what I agree with Aziz. And it's hard to gauge at the moment what we had before and what we'll have after. What we'll have after is emerging. Somebody isn't clear yet. Welcome more clarity on the answer. Nurse is very helpfully yesterday giving me some information behind this. Partial agreements, structures in each of the 4 places. And first of all, we may not know the total amount of the branch yet. We do know the total money is better careful. That's a substantial amount of money. So first of all, I would say that what comes after will be I would imagine, a delegated decision to those of our localities. We do have money. We have to decide how we're going to spend it. How we spend it, I think, depends on purpose. And as you say, it's it can't be purposeful. This is going to be left shift. This was full. And I think we could do a clearer articulation that is the priority. One might argue it's within the clinical strategy. I mean, it is. There are lots of things that you might argue it is a summit, a collection of neighbourhood plans. But I think it's more of that. It's a strategy proposal and 4 places to left shift. So I do think we need to understand that's the purpose. I think we need to be clear about that purpose in detail. I think we're due to get something back to the change portfolio board on left shift. How we take that forward. And that should then drive what this all meant to achieve in consultation with our place partners. What I would say is that what I've seen, current arrangements in terms of structure, the 4 places are very different. And I can't see the justification for that difference. And we need a bit of standardisation here and a bit of clarity. Those structures pay that money to achieve this shift. And I would argue personally that should be one of the priorities for 26-27. Not just clinical strategy and legal plans, but specifically for shift. So this really helps performance. It starts to uncover, I think, where we are at the moment. And I would argue a bit more assurance is needed going forward that this will create something that is going to be fit for purpose. Not sure where that lies in our governance.
Thanks, Jeff. It'd be interesting to hear from our ICB board member.
Yeah, it is referenced in the paper, but I think we can't emphasize enough as well the scale of change that's happening sort of across the landscape. So we are a massive change, lots of change there, and NHS also change there. So there are sort of inherent risks as we step into paper ones, other turbulence that we just need to acknowledge and be attentive to. I think it takes a lot of effort and focus from us as a leadership team, and also connecting with our partners. It just feels like nobody really yet has the full landscape of what it would look like post, and there's quite a big risk.
And what are those risks?
Just in terms of our connectivity with those colleagues with work streams, all these things have established ways of happening today. We had already identified that by transitioning to the leadership model, doing something and that caused some uncertainty. And colleagues will remember that as we stepped into that, prior to discussions about radical reform within our integrated care systems and NHS, etc., one of the anxieties that our place partnerships had were the disruptions. And now we've added a change on the other side of that interface as well. So it's almost like a target in terms of connecting those things together.
Julia?
I think one of the advantages that we've got from clinical aid model is the bringing together all of our community services and our urgent emergency care services together. So, and one of the things that we've had this conversations through interviews. They think some of the things that they're really prioritising on is how they're going to work with the acute services to understand what those pathways look like as you start to move them out into the communities. Even things like more diagnostics in the community. So there's some of those things are emerging with the ideas of those new leaders. We have been paying quite a bit of attention to the relationships in place, knowing that feels like a risk for some people on the other side of us. I wouldn't say that we've necessarily got that all right, but we've been paying a lot of attention to it. And we think some of the work that Steve Taylor's been helping us with in understanding some of the risks and some of the opportunities there. So I think it's still work in progress in terms of managing that risk. So I think the clinical strategy is the place where we're going to see the kind of most of the principles in there, and we're doing it with the work with the PwC work, is what of these pathways are best are required to be, you know, in a hospital, and what would be best served elsewhere, if in some of it, if at all. So I think it's, you know, we are paying attention to it. We haven't got the answers for that yet, but we are taking the right steps into trying to get to that place whilst this uncertainty is going on.
Yeah, thank you. So just building on Juliet's point, so Catherine Jones has been supporting us, hasn't she, through that connectivity, those relationships, the practicalities of who's going to which forums and when, because there's such variability, as Jeff referenced. So she's done a sort of weekly paper for us, hasn't she, that's allowed us to understand how those will be managed, and so to mitigate that risk. And we've also had some conversations about that direct connectivity to clinical groups into those places, so that we're already identifying the individuals that will participate in some of those critical meetings. That update paper is going to the SDLN board next time, the next auction.
Who's Catherine Jones?
Catherine Jones. She's
Wayne Jones.
yeah,
Right.
various motivation.
Yeah.
Catherine Jones.
Catherine Jones.
Make sure my hats are actually in the right place, because as I speak, I've got my NCA hats on. I think there's two sort of major challenges in problem. First of all, there's a significant organisational change risk that sits with the ICB itself, and what that organisation entity is going through. And you know, in terms of what does it mean, leadership continuity is an issue, relationship, delivery capacity, they're all being impacted as, you know, the restructuring and voluntary redundancy programme goes on. I heard a number of 400 talks about in terms of sort of the scale of the change in the ICB, so that is just bound to have an impact, isn't it? And then if you also factor it in as the things in terms of NHS England, so that's one place. And then there's like the transitional risk that sits, you know, sort of like getting an understanding about the hosting arrangements, potential for increase, you know, corporate headcount, and what would that mean for organisations like ourselves, who are also going to be sat in other conversations when people are going to be saying to us, your headcount's increased at a time when we're expecting it to go the other way. So there's a lot of risk that sits around it. I think there are some opportunities for improvement, though, and I think some of that's been alluded to. First of all, I think the clinical strategy conversation we've just had, I think there is an opportunity to embrace some of that. Some of the stuff we're doing around CLM, I think I would recognise there's still further work for us to do. I think this is where understanding about where CLM works and the conversation around at the neighbourhood level, I think there's still a gap that we need to articulate through. It may come as a part of the change portfolio or discussion that we have when this paper revisits, but I think we need to understand what that means. But I still sense there's an opportunity in there as opposed to being fearful of that. I would also say just a couple of other things. The better care funding, Suzanne would know that I don't think we fully understand whether it's the local government element of better care funding or the NHS element of the better care funding. I think right now, 2026, we're probably not having enough clarity about the impact and difference that is actually making to residents and what role it could be shaped to do into the future. So again, I think that's an opportunity for us to think about. I think one dimension I've been thinking about more recently, and haven't talked too much about it, is that when you think about where our organisation, some of the conversations we're having about what we might be in the future, you know, what areas you might want to grow, maintain, etc. I think there's a dimension for me that says, what's the place conversation beyond our 4 localities? And do we have any resource that we want to allocate that would look to serve the version of place beyond our four localities. So if you take dermatology as an example, we know in terms of skin cancer referrals, across the 271 GPs in Greater Manchester that would be making referrals to our dermatology service, we know the top 10 of those, 5 of those are Stockport GP-based practices. We currently don't have some resource that could be working with, for example, the Stockport locality, and other localities which drive demand in our organisation. And so it does make you wonder whether as a part of, if we're talking about left shift, what does that look like in terms of the interactions beyond our four locality space? And it just feels that those are some things for us to think about coming through. So I sense there's opportunities, but it's going to be forever in the articulation of.
Yeah, that's helpful. Thank you. Rafiq.
You did just a brief comment, triggered by what Owen was just said, and it just takes me back to when we started talking about the clinical reach or to the organisation. And at some point, in some of these discussions, we said it's going to be a clinically led organisation that can be better integrated across our sites and services. And then we started off by saying we want to consolidate our connection to place, right? And we then realized that actually we were talking sometimes to colleagues who that place, as we understand it, wasn't defining geography or our individual localities or the whole NCA footprint. And so we rolled it and we started talking about actually the focus is on connectivity to and responsiveness to our populations. And so I sometimes feel like our place discussion actually sometimes constrain what we should be doing. There's something about understanding it in a wider sense. There's a baseline place stuff that is typical in our localities and needs a particular approach. But the principle for us and for our services should be activity with the population that we serve and the people influence the flow and demand that comes from them. Something there that we think about.
Comments or questions? I don't think we've reached any conclusions there, have we? But we've maybe understood the scale of the challenge a little bit more. But I think it's something that, you know, initially probably really stand opportunities out, particularly around our streamlining of our clinical leadership model, which in theory should make that a little bit easier. And I suppose we've got opportunities to influence as well at ICB level too. So we'll continue to do that and keep abreast of how things are progressing. I don't think it should dampen our ambition around what we're trying to achieve, particularly what we've just agreed in terms of our clinical strategy around moving care closer to home and where people need it most. And that should still be important to us. Okay, thank you, colleagues, for that. If there's nothing else, we are asked to receive the update on the parties part, so we have to do that. Yeah. I'm going to move on then to any other business. So as you will see in the pack, we've got one item of any other business which is called Care in the Right Place, which is the references we made earlier to the event that we attended in terms of corridor care. Julia, are you going to take us through this?
Yes, thank you, and thanks to Julie for pulling this together. But it was based upon work that Chair Leah, Julia and I did at that event, which was an inspiring event and very much focused on how we meet the needs of patients. We were asked to go down as trust that's not performing well in terms of the amount of patients that we have on our corridors. There's a number of trusts there. We did hear about the journey some organisations have been on, which has helped them get to a much better place than us, including some organisations that are in really good places compared to us and others that perhaps earlier on in their journey and sharing how difficult some of this is going to be for us. And we did hear Tim Biggs was there from GIRFT, and Jim Mackey was there, and Doug Burns, so Royal College of Nursing were there. So there's a lot of weight behind this from a number of different angles. And what they're hoping is if they get a number of organisations in there and motivate us enough, and provide some guidance around some standardisation, things like definitions, that we'll start to lead the way. So they're not looking for us to follow a well-trodden path. They're looking for us to think about how we might kind of focus on this. And when you do focus on that, what difference it might make. They will bring out some definitions, and they'll work the GIRFT work that's already been shared with us, and will help in terms of what some of those changes might look like. This is a whole system change in terms of our organisation. It's what our acute services do and what our community services do, to ensure it's effectively flow. So if you're just thinking of like process mapping, it's flowing. It's understanding what point people come into services, and how we might move them through in a kind of way which meets their needs, depending on whatever pathway they're on. So we've been asked to create an action plan based upon the areas that are included at the back of this paper. We did consider them, most of them, I think, at the time we were there, and felt there wasn't anything there that we wouldn't want to do. I'll bring Leah in a moment, because we're doing some work on this spring, which is focusing on an area of this, which is those people waiting the longest in our department, to think about how we might learn from there. But I think the reason we want to bring it here as quickly as this is what the ask was, that the board collectively take responsibility for oversight of this and paying attention to this, and this being a key part, a key quality indicator for us. I think, Jeff, your point about what measures might we want to put in place, I do think we should be measuring. We need to think about what that measurement is, and I think when we pull together that plan, I think we should try and figure out what we might want to look at board, what we might want to look at policy committee or subcommittees of the board. I think that was all that I really wanted to say about that. I was going to bring Leah in to just talk about the work that we're already undergoing, and then just any reflections, obviously, from Chair and Julie on that.
Thank you, Chair. So we've got, as we're sprinting on the 4 hours, we also wanted to sprint in our progress and raise that awareness for our colleagues around responding to corridor care. We know it's something that our ED staff have found particularly challenging, given the numbers of patients that we've got on corridors. So we are also responding to the national ask of no delays over 24 hours in ED departments. We've put in place 3 times daily checks with people who are with the teams who are on for sites, and that is the lead directors, care organisation directors, and asking them and really putting that challenge in around beds, talking us through who are those patients, why are those patients still on the corridor. And we've addressed a number of things and some myth busting as well, as we are very early in it. We're only the 4th of March today, and we started it on Monday. So, but already we're coming across challenges around, we've got patients in our corridors, but no patients in our discharge lounges. Our discharge lounges are much nicer places than our corridors, and therefore if we push through patients into the discharge lounges, one this morning that couldn't go because they've been an inter-facility transfer and from one hospital, from one of our acute hospitals to Rochdale. So we know that the clinical ask, the acuity ask is much lower if they're moving to Rochdale. And it was no, they couldn't go to the discharge lounge. And when you put that challenge in, that it's nurse staffed in the discharge lounge, it's safe in the discharge lounge, it's a nice place in the discharge lounge. If we move that patient into the discharge lounge, that allows us to take a long way to off the corridor and out of the ED department, and then they will get their treatment sooner. So we are between us really putting in that challenge 3 times a day. We're also putting in a process around how we make sure that we've got executive oversight, as I said earlier, for Owen to be able to see who are those patients, when really an avoidable patient on the corridor is when we've got capacity in our beds in the hospital, and therefore why was it's a legitimate question of why wasn't that patient in a bed in the hospital. rather than in our ED departments.
And as we speak, the definition of corridor care has landed in our inboxes. From Sarah Jane, just the definition, and the definition isn't just patients on corridors in ED. It's the use of the temporary escalation space that we've been doing. And you may recall one of the issues that came through from the CQC inspection at Bury was having more patients than our established bed base was on female stroke ward, and the impact that was having on patient outcomes. So it will include those areas as well.
Okay, brilliant, thank you. Jude, did you want to add anything before I invite Owen to come in?
That's okay. I don't quite, is that right? Yeah, if that's okay, a couple of things I think that probably struck me as a non-clinical person as well in the room was that, you know, clearly none of us want to see corridor care. That was came through really clearly. I think the other thing that I liked was how traumatic that is for our colleagues to actually be treating patients in a corridor. It's not what they signed up to, it's not what they want to do. And I think a big part of the work that we need to do going forward, because yes, there'll be a plan, there's some really good practical steps we can take, but is engaging them in this and how positive it is. So hence one of the reasons why chosen the heading care in the right place, which actually is all lowercase care, so it cannot be acronym. But that is really about, it's not just about the care that they receive in the front door. It could be that transfer of care to somewhere else. It was a big discussion on the day. It's not actually discharging somebody, but possibly we are actually just transferring their care to somewhere else, even if that's to home, to their GP or whatever that might be. So I really would like us to embrace that language and really start thinking about what that is, because I know we've got this definition of corridor care now, but actually we all know that the corridor care is just a symptom of something else that's going on somewhere else in the hospital. Which is, this is not just about ED, and when I'm talking about engaging colleagues in it, I'm not just talking about ED colleagues, this is everybody in the community to kind of embrace this and help us to do it. I think I've heard you talk as well today about kind of 7-day service, and I think there's a temptation here, isn't there, to go, well, actually everything that we're doing could apply to this, and we should acknowledge that. But I would hate to see this getting so overloaded with every single thing that we're doing that we can't see the dial move. So it'd be really good to leave here today kind of agreeing some really early metrics that we can start seeing. We might change that develop over time, but let's see something change and not make this into something so big that it's not manageable. We don't do that.
Yeah, thank you for that. I think it's that balance between not making it too big, but not allowing it to be just somebody's responsibility either at the front door or at the back door, if that's the thing. But this is about creating it as everyone's responsibility. I think that's the challenge that often the NHS has, isn't around this, that it becomes a responsibility in the main of urgent and emergency care practitioners. And that's not what it's about, really. It's about everyone's responsibility. And so we did talk about, you know, we've got object appraisals coming up, haven't we? You know, could this be an objective for everyone? And that's the question we've asked in managing director interviews, is how are you going to contribute to that? Because, you know, and some people go, well, I'll help urgent and emergency care. Well, hang on, not necessarily about that, is it? So it's getting people to think about what their contribution is to that whole picture. So hopefully they're not making it too big, but everyone playing a part. Yeah, thanks, Julie. Owen.
Yeah, I think, Julie, that I was going to talk about that. Actually, I think 7-day working is actually essential with this, because if you take what Leah's just talked about, it's no good if that level of micromanagement only happens Monday to Friday. Mm-hmm. Do you know what I mean? Because all we're doing is that's self-evident. So we've got to understand how some of that works. And micromanagement is sometimes described as a kind of a weakness. But I think what we're talking about here absolutely requires an element of not just an element, it needs to be micromanaged. I think that's part of the thing we've got to think about. What does that micromanagement look like? And let's not get into the trap of thinking, particularly if we start to see some success, of thinking, oh, we can step back off that now because it's going to magically look after itself. It won't. but it requires a level of micromanagement, and we just need to commit to that and try and understand how that works. And again, it would be such a crying shame if the only dip into what happens elsewhere is the event that colleagues attended. There is lots of learning out there. We must be curious and keep going back to. So if we're developing something, we don't have to create something that's unique to us, because there's learning out there that we should be able to go and pinch with pride to bring back here. So that would be my encouragement of us. Please, let's not get obsessed with creating quote unquote an NCA model. And I did make an acronym of that script. So let's not do that.
Brilliant. Yeah, thank you for that. Thanks, Owen. Lorna.
Thank you. I really welcome this. I think, you know, I do exec on call. I'm not a clinical person, and I find it challenging often when talking to colleagues on sites with massive issues in flow, in patients in corridor. Recently, I met a family member who was 12 hours on a trolley in corridor, not in this region, but it hits home that that's somebody's mum, dad, or something else. I don't want us to lose sight of the opportunity of where hospices come into this, in that transfer of care and that end of life in particular. They are struggling in society right now financially, but actually have a real opportunity to work with trusts like ourselves, and we've got a lot in our region that really are prepared to come and help about that end of life and make life better at the end. I think that can help us part of this. I am back to the 7-day bit. That report earlier for me joined some dots in my understanding. It sort of solidified a few bits. One of the challenges that we see when you're exec on call is that if you're on call during the week, you can see, you know, how many people have been discharged, and then it fundamentally stops over weekends, and we come into a Monday morning and it's horrendous. I think there is something, I agree with Owen, actually, there's something about that. That's a key piece. That's almost foundational in terms of that's how we should be doing things. And there's a measure that says we've got to start to put that in place, because that talks to behaviour and approach to wanting to care. But I think this is really important and keen to help us as much as possible, even without a clinical background. I think there's stuff that we can all do. So thank you. It's a good report, really good.
Thank you for that, Lorna. It's really helpful. Thank you, Jeff.
Online to time at one of our board development sessions, just to briefly ask ourselves, what this is. I think it's basically most conversations I've had for a long time here. Why has it taken a national initiative? We've raised this all the time. I feel it's called why common care. So that's a bit negative. I feel it's hard to think about it. Secondly, I agree with what you said. Actually, it bears repeating. I feel very strongly that this is, of course, our organisational responsibility. It's not just the steady 7 days that we're working, all that, I think, will help us solve this problem and achieve our performance targets at the same time. But I also really don't want that to stand in the way of doing what Leah said. So every day, 3 times a day, going and say, why is that person there? I really think those who are on those trolleys or the something like that, you know, to do it now. And finally, whilst this is absolutely about flow, it's also about flow in, flow out. You can't do that without the place partnerships we just talked about. So when we're talking about the Better Care Fund and you know, it's here and now. You know, what's our responsibility to make sure that those partnerships are placed at neighbourhood level are working to help us solve this problem.
No, absolutely. And, you know, I think we probably all share that, you know, it shouldn't take something like this. But I think what I found really helpful was that, you know, 4 members of our board were there hearing the same message from a range of different people, and it all landed probably in very different ways for us all, but it all really kind of, if, you know this is a challenge, we talk about it at probably every board meeting, but I think just to say, no, this is what we're going to focus on now. And everyone being of the same mindset and the same willingness and attention to it was kind of powerful, I suppose, from my perspective anyway. So I think if this is the impetus we need to push on, then so be it. And I think I think we owe it to our workforce, we owe it to our population, because we can't just, and I think you instinctively know that when you walk around the hospital you see it, but when you, I suppose, sometimes you think, oh, well, it must be just me. To me, it must be just bothering me. And I think what we heard, not just us from our trust, but from lots of other colleagues up and down the country, no, it's not okay. And I think that was the point. So I think that if that corrals us to do more now, and I agree with you, and I think that's the point Owen was making about the micromanaging is necessary. We can't just say that's someone else's responsibility. But I think that's the other bit about, it's a bit like, what's your contribution to putting someone on the move? It's what's your part in that? And it's the same with this, isn't it? How are we going to stop that happening? And everyone has part to play in that. Whether you're in the community, whether you're in the hospital, whether you're in, kind of the, post room, what's your contribution to that? So I think that's what I was kind of hearing. So,
Thank you, Chair. And I think there's something for us about really being purposeful in how we talk about this and making those connections. Julie's talked about engaging with colleagues, but colleagues have told us through various forums, either through the staff survey, over a number of years, or through Begin to Speak Up. But I think it's really important for us to be connecting care in the right place to, you told us we're doing this, you raised Speak Up, we're doing this, because if we're not making that clear connection, then people won't automatically make it. And we need to assume that we're purposeful about how we do this, and that brings power, and it brings the power back to those colleagues who are seeing this, as you say, Sheena, day in, day out. It doesn't matter if you're a porter or a part of catering or a nurse or a doctor, an AHP. It's connecting back to, you've told us and we heard it and we are doing this about it.
Thank you. So I don't know whether we were planning to talk about those metrics now, or if that's going somewhere else or coming back. What's the next steps then? Yeah.
I think we need to look at the guidance that's coming out nationally. Obviously, one measure would be a measure of corridor care. So I think we should perhaps just take that. We'll get that into the outcare. We'll start collecting that data, and we'll start to report that, and then we can then think about what other, I guess, where our priority areas of focus are and what measures might be associated with those activities. We can at least commit to that, I think, to gathering the definition. I don't think that's going to be easy, by the way, because I think this is manual. We're doing a point prevalence for the next few weeks on where patients are. So we haven't got a whole scale electronic bed management system where we could identify that. This is manual data collection, unfortunately, until we are looking at the feasibility of a bed management system, which might make it a little bit easier, but currently don't. So yeah.
Okay, and we'll circulate the guidance as well. I just mentioned that's arrived, and so we'll circulate that forward. And I don't, the notes that we had from the session as well, I'm sure we can share those as well with board members, and that might be helpful. Okay, so we've got 3 recommendations there about acknowledging the seriousness of the issue, done that, and agreeing a high level focus on this, developing an action plan, and agreeing the initial metrics. We have those. three recommendations, yeah. Perfect, thank you. Okay, thank you for putting that on the agenda at the last minute and the colleagues accepting that. I think that was helpful. Okay, so on the agenda is also a copy of the closed session items that we considered at January and February's board. That's just for information. The next meeting of the public board in public is Wednesday, 6th of May at 9:30. So I'm going to conclude now that we exclude the press and public from the meeting at this point on the grounds that publicity of matters being reviewed will be prejudicial to public interest by reason of the confidential nature of business. The press and public are requested to leave at this point. Okay, thanks colleagues.